Lagos State chapter. The theme of this conference is Advancing Sustainable Financing and Workforce Capacity for Equitable Healthcare Delivery in the Global South. And this is particularly important at this time. None of us is new to the challenges that we face in the Global South. All sorts of things, emerging disease trends, and it speaks to the determinants of health outcomes. This theme, particularly at this time, speaks to the strength, the resilience, and preparedness of our health systems, which is why we're having this discourse. We're aware that we face a double burden of diseases in the Global South, chronic non-communicable diseases, communicable diseases, as well as our own peculiar health challenges, shortages in workforce, uneven distribution, migration challenges, catastrophic health spending, and these are all the issues we're here to discuss. So in this meeting, it's critical that we pay rapt attention. We're going to be examining data and finding context-driven strategies to help improve these health outcomes, as well as build a network of committed partners in this place today. So kindly pay close attention. Before we go into the conference proper, I'll call on one of the staff of the Marriott Hotel to give us a security briefing. Thank you so much.
Every tear becomes a song of a love that still feels strong.
Good morning,
Even though it's been
good
so
morning, beautiful ladies and handsome men. All right, my name is Mikel Sina Ojokunyi. I'm the security, the one in charge of this floor. All right, I'll just keep it short and brief, like the name implies. Security, safety, a brief. I welcome you all once again to Lagos Marriott Hotel. All right, this floor that you are is event. Underneath we have car park 1 and car park 2, and above us that's where we have the reception area and the guest rooms, on and on like that. Okay, this is Joelugu Nike, number 122, Joelugu Nike, GRL, Lagos to be precise. Okay, let me go straight to the point. Okay, at the course of this program, attention please. At the course of this program, you hear the fire alarm. Please do not ignore. We all know safety and security is everybody's business, because what is small to you, you don't know what it is to the next person seated or sitting beside you. So in Marriott here, we target as see something, say something. So that's the whole thing. All right. At the course of this program, if you hear the fire alarm, please do not ignore. We advise everyone to dash down to the nearest available exit. And where is this nearest available exit? If you ask me, which I tag as safe haven. As you're driving in or you're walking by foot, just at the corner of it there, you see the Monster point. That's where our guest is meant to assemble, and we'll be doing our head count. Why? Is because we want all our guests to be evacuated. We don't want to leave any guest behind, because our guests are very, very important to us. You are happy, I'm happy, everybody is happy. That's just the goal. So that is at the main gate. That's where our guest is meant to assemble. We'll be doing our head counts to make sure everybody has been evacuated. Still on emergency. How many exit doors do we have? Let's count together. We have 1. Behind you we have 2. Beside you we have 3 and 4. All right. These doors are intentionally designed for one purpose. In a situation whereby you have an incident, emergency situation, and everybody is dashing down to one door, who can tell me what will happen? Thank you very much, madam. Stampede. So we all here can attest to the fact what stampede, the damage stampede can do. It's even worse than the incident itself. So that's why you see we have many doors for our guests for easy route. So you can take there, you can take here, take there, and take there. So you don't need to rush and just navigate your way around to the main gate. All right. Okay. Another one again. We discourage our guests from using the elevator. Please, while the alarm is on, you hear the voice. This is an emergency. Please evacuate. This is an emergency. Please evacuate. Don't ignore that voice. All right, please. And no one is encouraged to use the elevator pending when the alarm will be rectified. But via that, we'll be addressing you guys via the public address system if you're to re-enter the building or not. All right, that's on that. Okay. All right, we have armed policemen in the building in case you have any issues, queries, or anything as the case may be, and you're not satisfied with our security. We have external armed policemen to make sure they arrest any issues or queries that you have. But before that, feel free to approach any of us and we'll make sure we attend to every concern or complaints that you have. All right, we have 2 restrooms on this floor. If you step out of this door, by your right hand side, you see one, and behind you, straight down by your left hand wing, you see another one, male and female respectively. All right. We have, if you look, we have the mini overhead caps that we have on top of it there. We have the sprinkler. That's, if you check above it there, we have the sprinkler and the smoke detector. All right, as tiny as dusty powder or white powder, as the case may be. If it gets up there, it can trigger alarm as well. That should show you how sensitive the smoke detector is. What I'm just trying to tell you is you are in an environment where the security and safety is well equipped, because we take our guests dear to our heart. We have the smoke detector, we have the fire curtain, pending when the fire response team will arrive. We have the sprinkler, we have the first aiders to attend to our injured guests when this is ongoing, and we have the fire wardens to fight fire as well. And mind you, the fire response team are not too far away from this building. That's to show you, just in case there's any fire, they are less than 10 minutes drive away from here. Show you that is it. And lastly, I'll leave you with this because of our time. Please, your handbags, your phones, gadgets, or anything that you feel that is personal to you, please do not leave anything unattended to. Maybe you want to go out to use the restroom, to have a fresh air, make phone calls and the like. Please, if you have anyone that you can entrust your personal belongings to, is fine. But aside that, you can as well go ahead with it. Any questions or questions? Alright, in the absence of none, thank you once again for having me. Enjoy the rest of the event.
So thank you. Just to clarify, because I had a challenge looking for so the toilet closest to us, the restroom, is to your right, and at the end of that corridor, the female restroom is on your left and the male is on your right, just at the corner here. Some other housekeeping. The Wi-Fi code for this building is LMH25, all caps, LMH25, all in capital letters. So that's the latest conference. I think that's the name of the Wi-Fi. So LMH25. However, kindly put your phones on silent. Thank you. Please bring out your phones and put your phones on silent so that we're not distracted. And as much as you can, put your phones away so that we're all paying rapt attention. At this point, I would like to welcome someone who is very dear to me, even though I have atonement to make for my many sins, my mommy, the person of our chairman, the Association of Public Health Physicians of Nigeria, Lagos State Chapter, in the person of Professor Yetunde Kuyino. Join me as she comes up stage.
Bathed in light and bound by truth. Every step is touched with grace. In the gentle hand and
Good morning, ladies and gentlemen. I remember 2 years ago, we were at Providence by Mantis, and that day I wasn't really feeling fine at all. And I said, how can we be doing conference and I would not be available? So if you look at that day, I look so stressed. But I thank God that today, to God be the glory. God is really faithful. So it is with immense pleasure and deep gratitude that I welcome you to this scientific and biennial conference of Aphpn. You are my family, you are my people. Without you, there is no Aphpn. And without you, there is no conference. I want to thank you very much for coming early. Edition since Lagos State Chapter inaugurated in 2013. Give me honor to stand here today, surrounded by the finest minds and dedicated professionals who continue to carry this mandate of public health with excellence, resilience, and our theme for this year is Global Health Under Threat, Advancing Sustainable Financing and Workforce Capacity for Equitable Healthcare Delivery in Global South. It is very apt. It is timely. Across the African continent and indeed the whole world, health systems are confronting unprecedented pressures, emerging infectious diseases, widening health inequities, climate-related vulnerabilities, insecurity. In Nigeria, in Nigeria, it started like a joke, maybe about 10 years ago. And just yesterday, someone was telling me that along that axis, 4 people were kidnapped yesterday. Insecurity that we are facing, the persistent challenge and inadequate financing, which has been worsened by recent sudden withdrawal of much of foreign aid to health interventions and systems. At the same time, our workforce continues to grapple with migration, the jackpot syndrome, burnout. Remember that doctor that dropped dead after 72 hours of continuous work, and structural gaps and that threatening continuity of care. On Monday in last week, I don't know, the resident doctors resumed, and I learned that today, GSO have started strike. That's the workforce we work with. So as public health physicians, we are called once again to lead with clarity, courage, innovation. This conference serves as a reminder that our profession remains the backbone of prevention, preparedness, and system strength, in particular within the dynamic, complex environments of the Global South. Over the next 2 days, we will engage in rigorous intellectual exchange guided by sub-teams that speak to both our national realities and global priorities. Today begins with conversations on digital health, telemedicine, artificial intelligence, critical innovations shaping the future of care. We are privileged to host leaders who are not only breaking ground in their various fields, but are actively redefining what equitable access can look like in Nigeria. Their contributions will push us to reimagine service delivery, bridge operational gaps, and harness technology as a powerful public health tool. We also examine the postgraduate fellowship program and its significance for strengthening the health sector. This dialogue comes a pivotal moment when our role of public health is evolving and must be better integrated into the states, the tertiary, community, and national health structures. With esteemed leaders like our Prof. Akin Oshibogun and other high-level stakeholders on the panel, we have the opportunity to articulate a clear pathway for the sustainable utilization of our specialists across all levels of the health system. Tomorrow, we continue with an equally critical sub-team, rethinking health sector investments. As financing remains one of the greatest determinants of health outcomes, this session will challenge us to move beyond traditional models towards approaches that are inclusive, equitable, and sustainable. With key voices from the government, HMOs, global health organizations, private medical practitioners, and even the most important voice of all, which is the patient, will explore truly people-centered strategies for advancing universal health coverage. In addition to these rich discussions, this conference will host scientific presentations, poster sessions, systematic review, training, and deliberate engagement with policymakers and health leaders. These activities reflect our identity as scholar practitioners, bridging evidence with policy, research with implementation, and idea with action. I would like to sincerely appreciate the local organizing committee for their extraordinary dedication in putting together this high-quality event, as well as our sponsors, partners, speakers, and delegates, all of you, for your invaluable support. Your presence here affirms our shared commitment to strengthen the health of the people and the systems that serve them. As we begin today's conference, I encourage each of us to engage fully, collaborate intentionally, and reflect deeply. Let us leave this gathering not only enriched with knowledge, but empowered to drive meaningful change in our workplaces, our communities, and our nation. Once again, I welcome you all warmly. Thank you, and I wish us a productive and impactful conference. Thank you.
Thank you, ma'am, for your welcome remarks. Professor Kinka, consultant, public health physician, Lagos State University Teaching Hospital, who is the head of the scientific subcommittee, to give her opening remarks. Thank you.
Okay. Good morning, everyone, and welcome again to this lovely conference, Aphpn Biennial Conference 2025. So I have this honor and privilege to chair the scientific committee for this conference. And I just want to quickly read out to us the definition of research: systematic investigation into the study of materials, systematic gathering of data and information for its analysis for advancement of knowledge in any subject. So we're here today because we're public health physicians and we want to get more knowledge about public health and how to advance the health of our communities. So basically, people have gone on, they have conducted research, different types of research, and they have done it in systematic ways, all right, different ways, the ways in which they should. If they have not done it the proper way, this is the time for us to take a look at that. So we're going to be looking at a variety of research, abstracts that were received, and we are very grateful to the House. You responded to our call for abstracts. Abstracts were actually submitted for this conference. And so the abstracts, thank you very much for that. We are grateful to everyone that submitted. And then the abstracts were assessed, and we have 10 abstracts that were selected for oral presentations, and the rest of the abstracts are for poster presentations. Now, among the abstracts, right, for oral presentations, we're going to have them simultaneously. So when the time comes, the hall is going to divide. So these first two rows are going to be on this side for the team A, and the last two rows will be on that side for team B. So we're going to listen to our presenters, and they're going to tell us what they have done. And I would love you to kindly please pay attention, and when the time comes, choose the preferred session that you would want to listen to. And we're going to have 6 wonderful people being our judges. So we're going to have 3 judges for team A and 3 judges for team B, right? And we'll assess the oral presentations, and then they will also assess our poster presentations, which will come up. So this will come up at about around 2 o'clock. That's when the poster presentations will come up. And these will also be assessed. And everyone is encouraged to please be a part of this, listen and ask questions, right, about what was done, so that all of this information that we have brought together can actually make a difference in the health of our people in Lagos State as well as the whole country. So once again, I want to say thank you very much. Thank you.
Thank you so much, Professor Kinka. We'll be going into the next session right away. And to introduce and give us an overview of this session, I'll be calling on Professor Ololade Wright of the Lagos State University Teaching Hospital to give us this overview.
Good morning, and welcome to the very first scientific session for our conference. The sub-theme for this session is Innovations in Health Systems Strengthening, Leveraging Digital Health, Telemedicine, and Artificial Intelligence to Bridge Operational Gaps. Now, as public health professionals, and more importantly, as an association, we must recognize that strengthening health systems involves making healthcare not only accessible, but reliable, efficient, effective, and of good quality. This is if we're hoping to attain universal health coverage. Now, this process of strengthening health systems encompasses every link in the healthcare value chain, from policy and planning to healthcare delivery, monitoring, and evaluation. And so to improve healthcare, it's important that we address every component of the healthcare system. Rather than focusing on one aspect or the other, we need to focus on all aspects holistically. This then means that we need to address issues of funding, issues of healthcare finance, strengthening of healthcare systems, training of different categories of healthcare manpower, infrastructure development, whether that means that we need to build more clinics, more hospitals, or even upgrade existing structures. We also need to ensure that we have adequate equipment in all of these facilities, and then ensure sustained availability of medications as well. We cannot also overemphasize the importance of data. Healthcare data management is topmost on the list if we want to talk about policy decisions. Now today, we're going to focus on technology and how technology can make healthcare seamless and smooth so that we can have better health outcomes for the good people of Lagos and Nigeria as a whole. We're all quite familiar with the challenges of healthcare systems. We have shortage of health manpower, weak referral systems, poor diagnosis, and all of that. And so we're going to look very critically at a few questions that I would list, and I'm sure we'll have a few more additional questions to add. We're going to ask, how can digital health become a core part of the Nigerian healthcare system, more so if we're talking about the 21st century? We would also want to know how we can ensure that these digital innovative tools can reach every community, starting from the high-rise buildings in Ikoyi, Victoria Island, and Lekki, down all the way to rural communities and settings like Ajaratopa and Agbatotome in Badagry. These are some things that we need to look into. We also want to know how innovation can translate into measurable improvements in health outcomes so that we begin to have faster diagnosis, we have shorter wait times, and then there's better continuity of care, and of course, stronger disease surveillance. And so this morning we have carefully selected some distinguished resource persons who will bring complementary perspectives on some of the core pillars for digital health solutions. We're talking about innovation, we're talking about regulation, we're talking about targeted disease solutions. And we all know that these pillars align with our core mandates as a professional association. So at this point in time, it gives me great pleasure to invite, first and foremost, the first speaker, who is going to be speaking on innovations in health systems strengthening, leveraging digital health, telemedicine, and artificial intelligence to bridge operational gaps in Nigeria. Please put your hands together as I invite Dr. Solomon Oyetoyon. Keep clapping for him, it's not easy.
Good morning, everybody. Good morning, everybody. Let me first start by apologizing that I swallowed a toad yesterday night, and my voice is not, this is not my usual voice. So please accept my apology. So that is the first of the series of apologies I'll be making this morning. The second apology is that if you look closely, you'll see that I've changed the topic. The topic that I was supposed to speak on is leveraging on digital health, telemedicine, and AI to bridge operational gaps in Nigeria. However, I actually wanted to make the presentation to be an operational one, which is, I want to share the story of my experience in my workplace. So that is why I decided to change the topic. I hope the LOC will forgive me. Actually, I messaged them I would change the topic, but they refused. But I was stubborn, and that's why I'm begging you to take my apology. All right, so we'll be speaking on how we use the digital health to solve some operational issues in Lagos State Health District 1. And before I go on, I want to greet my ogas. so that they would not be angry with me. I want to greet my permanent secretary, seated permanent secretary for a farmer. Welcome, ma. I want to greet Professor Kuyenu, the chairman for the association. All right, and Professor Wright, thank you for giving me this privilege to display what we have done in Lagos State Health District 1. All right, so I'll be speaking, I have just 20 minutes, so I'll be speaking to the topic using this outline. I'll try and introduce the topic and marry it to the initial topic given to me. And we'll look at what some few operational gaps that we had. And then I'm here to just share some stories to you. This is not a scientific research, it's an operation. It's not a scientific presentation, but an operational one. So I'm here to just tell stories. We'll talk about some of the digital technology that we use to solve some operational issues. So we're all familiar with what health systems are. And they are all the organizations, the people, and the actions that are intended to promote and restore health of our people. And we all know the 6 building blocks of health systems from the framework of WHO. And you see there, central there is what? Is access to medicines and technologies. Access to medicine and technologies. So, digital health. Digital health comprises all technologies, tools, and systems that are used to improve health outcomes, and they are used by individuals like you and I in the health family, and individuals that are outside the health families, is meant, and policymakers, to help us to have better health outcomes and to enhance efficiency in the health services that we render to the public. And this includes mobile health, telemedicine, electronic medical record, or which is the one which is all encompassing electronic health records, and so on. Some of us are wearing smartwatches and monitor our steps every day. Is part of digital health. Now, the big thing, AI, artificial intelligence. Artificial intelligence. Artificial intelligence is simply how we can use tools to help us make decisions, to what the human intelligence will have done normally. We want machines to help us do it. And as we go on in this short discussion, we're going to look at it together, how we can deploy artificial intelligence to improve health outcomes in our health systems in Lagos State and Nigeria as a whole. So these are just some of the few operational gaps that we have in Lagos State Health District 1, which we can also say probably affects other health systems in Lagos State. We have shortage of staff. Even the shortage, the staff, the few staff that we have, they are unevenly distributed across the health facilities in Lagos State. We have fragmented systems. If you have been to teaching hospital before, I was speaking with someone recently, I think day before yesterday. I had a patient in the teaching hospital that I went to visit. And I was thinking, how can we reduce bureaucracy in our health systems? I'm sure you agree with me. Every department in a teaching hospital behaves as if it's a separate institution. And if you are being referred from one department to another, you'll have to start almost all over again. How can we bridge that operational gap? Our data is also fragmented. If I call on my MIE officer to give me data for delivery from January to date, the figure she will give me will probably be different from if I go to the source to get that same data from all the facilities that the MIE. So we have fragmented data too, which will always affect decision making. We have problems with referrals in Lagos State. In fact, some years ago, when I was still medical officer of health, if I refer a patient, if you want to refer a patient, I tell my doctors, please don't refer to this general hospital, because it's always story of no bed, no bed, no bed. So we have issues with referral. Not to talk of issues that pertains to transporting the patient there. But we have already transported the patient there, taking the patient in. Even Ilera Eco patient, insurance patient. I was discussing with one of the senior officers in Lashma recently. I had a patient in General Hospital, and transferring a case from lawsuit to the General Hospital in question became an headache. And the husband of the woman almost was saying that I'm not doing insurance again because of the headache he encountered. We have limited real-time supervision across, and we know that what is not supervised, it would hardly be done well. So we have limited real-time supervision, and this is one of the issues that we found out when we started Lagos State Health District 1. We have unequal service quality across all our primary health centers, unequal service quality. So how can we use digital health? How can we use technologies to bridge this gap? We have poor emergency readiness, especially we all know that diphtheria is rearing its ugly head in recent times. And we had issues of cases in some boarding houses in one of the schools within my jurisdiction. And before we could get the team ready, took some time. Unfortunately, one of the 2 confirmed cases, we lost them. So any of these operational gaps should become the problem statement for innovation. Should become problem statement for innovation. The starting point for quality improvement is to identify the problem. So any of the operational gaps in our services should be the problem statement, so that we can try to run with it and solve the problem as much as we can. right, so Lagos State Health District 1, like other districts, were created around second half of 2023 by Mr. Governor, Mr. Babajide Olushola Sanwo-Olu, and his vision was to bring health governance to the grassroots so that the people can have a feel of the governance of primary health services. And when we started, like other health districts, we met with a lot of gaps, and which form part of the story I'll be sharing with us today. So when we started, we came up with our vision. And the vision is to create a model for efficient a network of primary health services as a model for other districts to copy and for other PSCs in Nigeria to emulate. And to achieve this, we set out to promote three things: excellence, innovation and team spirit among the workforce. And our core values are professionalism, cleanliness, focus, and safety. So let me start with this first story. So sometimes, just shortly after the district was created, we had a case of baby M.A., who was brought to one of our health facilities at 6 weeks birth, had the series of vaccinations, one of which was pentavalent vaccination, which is given in the left thigh. 2 or 3 weeks after, 2 days after, the baby had swelling on that left thigh, and afterwards, the baby came to the facility, and the mother was asked to use pain reliever and use ice block on the thigh. However, we did not see the baby at the facility until 3 weeks after. And by that time, the legs was already well swollen, and the baby started running fever. The baby was seen by a doctor at that point, and the doctor ran some tests, and it was discovered that the PCV was 23%. The baby was around 7-8 weeks then. And the doctor asked the baby to come back 2 days, gave the baby antibiotics, and asked the baby to come back in 2 days' time for follow-up. Eventually, the parents went home, and we did not hear about them until, I think, 2 weeks after that. By that time, the baby had already had a below-knee amputation. Very sad story. So when the case got to us at the district, we felt, from the story I gave you, I'm sure you must have, I saw some people shaking their heads. I'm sure you know that there are some gaps from the story I gave you. So we sat down at the district, and we felt, if this is happening in one PSC, there's a possibility that it's happening in other places. So how do we look at this as a whole so that it will not happen again? Although from investigation, we discovered that the parents have started applying some other things, which probably must have made the limb to be very, very, for her to be septic eventually. All right, so the second story is about Mrs. Katie, a 29-year-old gravida, 2 para 2 as at the time, of the story. That was around third quarter of 2023. Coincidentally, she was Ilera Eco patient. And when we got to know about it was when Ilera Eco notified us about it. What the gist is she's Ilera Eco patient booked in one of our PSCs, and on the date of her delivery, she came in around 6 p.m. that fateful day, and she, from the account of the midwife, she said around 6 p.m. she was already 4 cm dilated. And she did not deliver until 8:30 p.m. the following day. And she was delivered of a macerated baby. Shortly after she delivered, she started pouring blood. So she had PPH. They gave, put on anti-shock garment, and was referred to a secondary facility. Because it was a prime case, we had to keep an eye on the case. She got to GH close by, and she had about 4 or 5 pints of blood, and she eventually died, I think, 48 hours after admission at the secondary facility. So these are stories that can be preventable. These are stories that can be preventable. This shows a lot of gaps that we see in the PAC level. So we thought of how we could, what we can do in real time to the consultant. So the second innovation that we deployed is what we christened Health Site. We tried to use this to have an overview of all the primary health centers under our jurisdiction. And it's such that it has different layers, and I will try to run us through it. So this is like the dashboard for myself. We have not gotten there yet. We hope to start using it for upcoming appointments for our patients as time goes on. Actually, what gave birth to this was while the district was established, there was a baseline study that was done across all the primary health centers in Lagos State. I found out that Lagos State Health District 1 has a very high number of non-communicable diseases, especially hypertension and diabetes. So we felt that we should look for innovative ways in which we can send reminders to them for their appointments to come. That was what gave birth to this, but eventually it has metamorphosed into various aspects. If you can see, you will see that we have the dashboard homepage, we have the patient interface there, we have an interface there which has not yet been deployed, to which the patient can book an appointment ahead of time. And then we have an interface there in which we do assessment, quarterly assessment of all the PACs in the district. And as we do it on our phones, it goes to the back end where it gets populated, and we'll see how it looks like in the next slide. The next slide will show the interface for reports. Okay, so this is if we are going out for assessment, the the supervisor that is going on for assessment. This is the place you log in, the district, the local government you are doing the assessment, the PAC you want to assess, the quarter, and then after you have filled this first page, you start answering questions, about 205 questions to assess the PAC, and then the data from that goes here. So we can see from a glance, the permanent secretary can see that I have 34 functional primary centers in the district, and only 60 have reported for this assessment. Can we see? Only 60 has reported out of the 64. And we have a total of 1,118 staff. We have permanent staff, 863 temporary staff. So it helps to make decisions. We know the distribution of the staff. You can see the total patients seen for that quarter, those that were inpatient and those that were outpatients, the general attendance for that quarter, that's quarter 2, 2025. One of the most interesting parts is this part. You can see Agege local government has 149 workers, health workers. So at a glance, we can see how the health workers are being distributed. And if need be, we can redistribute them. So to conclude, I want to leave us with 2 questions. Are we using digital tools to solve old problems? Or are we still clinging to the old habits that create new problems? Shortly before I came up, I was discussing with one of my ogas, Professor Olufumilayo. And we were talking about how 200-level students, medical students, have started deploying artificial intelligence. As you and I seated here, are we still clinging to the old problems? And secondly, how much longer will we allow limitations of analog system to shape the quality of care in our health systems? Thank you.
Distinguished ladies and gentlemen, please let's put our hands together once again for Dr. Oyetoyo. I'm sure we all have many, many questions for him. I also have a few questions. It's impressive that Lagos State is doing so much. Obviously, we're not doing enough, but let's put our hands together for Lagos. Lagos is working, as they say, right? It's impressive that when he talked about the REMAS, how remote monitoring and supervision modular system. This is really great. This is fantastic. I was also quite impressed with the health site platform, which helps, in monitoring and tracking performance of primary healthcare systems and even of health of our healthcare workers as well. We hope that this will be the beginning of greater things, not just for Lagos Health District 1, but for all the other health districts in Lagos and Nigeria at large. So we're going to go deeper right now. We're going to have more robust discussions And to anchor this session, we're going to have a panel discussion. So it gives me great pleasure to invite my friend and sister, the former chairperson of Aphpn Lagos State Branch, no other person than Associate Professor Tolu Olufunlayo, to come serve as moderator. Please put your hands together for past efforts and for ongoing efforts. She's still working. She's a member of the EXCO, a very strong member of the Association of Public Health Physicians of Nigeria. So she'll do the introduction of the other members. She'll introduce the other members. We have some very big fish in the house that will come speak to us about telemedicine, artificial intelligence, and digital health solutions. Again, put your hands together for Tolu Olufunlayo. Please come up, sis.
Good morning, everyone. The chairman, Aphpn, Professor Kuyinu, chairman of the local organizing committee, and the members, the session chair, Professor Wright, our esteemed speakers, esteemed members of our great association, all our guests, ladies and gentlemen. Good morning. I'm very glad to be here to coordinate this panel session, which I believe will take this topic deeper and further. And what we're aiming at this morning is not to talk and do nothing. We are looking at solutions. We hope that by the time we gather next time, we'll be talking about what this conference has been able to put out to drive innovations in health systems. And I must say, I'm very impressed at the presentation that we just had this morning by Dr. Oyetoyo on what Lagos Health District 1 is doing. So let's just dive straight into it because we don't have time. I'll be calling up the speakers for the panel. And I think I should first of all bring back Dr. Oyetoyo to the stage because he'll be part of this panel. Dr. Oyetoyo, please. Also, part of this panel this morning, we have very esteemed speakers. We have the permanent secretary. Okay, please let's welcome Dr. Oyetoyo again. Thank you, you're very welcome. So we have the permanent secretary of the Health Facility Monitoring and Accreditation Agency, popularly known as HEFAMA, a very important agency, and they've been doing a lot in Lagos State. She will be speaking on quality control and patient safety in this digital era, and we want to find out how they've been able to leverage digital tools. So please, with a warm welcome, let's put our hands together for Dr. Abiola Idowu. Please put your hands together and welcome her warmly. Thank you very much. Continue to put your hands together, please. Thank you. Good morning, ma'am. Thank you. The other member of our panel this morning is the Chief Operating Officer of OncoPaddy, which is a digital oncology platform improving specialist access and continuity of care for cancer patients. This is very innovative, and I would like us to look forward to what she would be telling us about how they are impacting on cancer care. So with a warm welcome, let us put our hands together for the Dr. Adaora Enyi, the COO of Oncopadi. Dr. Enyi, please. Thank you very much. Thank you. Thank you. Okay. So Aminat Abolade will be ably representing Dr. Enyi. Aminat Abolade, please can we welcome her very warmly? Thank you. So my panel is complete. So we're going to dive right into it. Thank you very much. So thank you very much. So I think I'm just going to start from the end, especially since Dr. Oyetoyo has just concluded his presentation. I think that was brilliant. Can we put our hands together for Lagos State? Those are really brilliant innovations, and to think that that was done in, under 2 years of the health district being formed. So thank you for that presentation. My first question to you would be, yes, we can see the improvement, what these have brought to bear, but how have you been able to measure the effect of these two innovations? You might want to take one or the other, or the two of them. So essentially what I'm asking is, what monitoring or evaluation systems have you put in place, if any? And if you haven't, what are you planning to do? Because like you said, some of these things, you've done them, you've been iterative about it. You've seen something, trying to solve a problem, and you've moved on. So can you take that for us? Thank you.
All right, thank you very much. For the health sites, we every quarter, when we finish the assessment at the district level, the PS sees the dashboard that I just showed us, and then we have a meeting. First at the district level with the directors, and then we'll see, like, for example, for second quarter, we found out that out of 64 functional PSCs, only 60 reported. So the PS wants to know why. Why only, what happened to the 4 PSCs? I think I remembered one of them was being under renovation and so on. So in a way, we want to know why from that dashboard. Now, also, the dashboard also provides like a summary of reports that we share to all the medical officers of health in the district, for them to know that in 1, 2, 3, 4 of my PSCs, these were the issues that were found out in those PSCs in the last assessment. And usually the medical officer of health should also give us a report as mandated by the permanent secretary after we have given him or her that report on what he or she has done to reduce that gap. So it's mandatory, after we have shared that report, must give us a report back so that we know if you have started taking steps to reduce that gap.
Okay, thank you very much. Thank you for that. Let me move to our other panelists. I'll be coming back to you, Dr. Oyetoyo. Dr. Idouma, the PS of Hefama, you are most welcome. Thank you very much for being in our midst today. Hefama plays a major role in monitoring of health facilities and definitely is largely responsible for the quality of healthcare delivery in Lagos. Can you tell us how Hefama has been able to so far deploy digital technology of whatever form, if you have, been able to incorporate any tools in tracking, supervising, or accreditation of hospitals? Would like to know about that. Thank you.
Thank you very much. Good morning, everyone. In 2019, the agency deployed what we call eFarmer. It's a platform for registration, and it enables our healthcare providers to register their health facilities without visiting us incessantly. They're able to upload all their documents required. For example, we want to know what the facility looks like. They send a schema diagram so that from the onset, where we have an idea, we know the location, we're able to, we also request for the proposed flow of the facility. And then the health care workers, they upload their certificates and their current practicing licenses. So from the onset, we know that they meet all the requirements before we go out to carry out an inspection. So we also have what we call Aphpn app that we use for monitoring and inspections.
Sorry, what did you call that app?
Aphpn.
Health Fit.
So
Okay.
I smiled when he said health site. So we have an Aphpn app for monitoring and inspection. We use it at the health facilities to capture their, we have the monitoring form, the format is on the Aphpn app. So we use it to capture information on the facility, to see if the facility meets compliance. But all our tools, it doesn't actually remove, there's also a place. I also want to just emphasize that there's a place for, even with all these innovations, we cannot remove the place of actual supervision by people. But we have digital tools that we deploy. We're not yet at the stage where, even when we are not at the facility, we can request for, for us to be adequately supervised, but we try. So, for example, when we go to a facility and they do not meet compliance, they can upload their documents back to us to see, okay, this is the improvements that I've been able to do. The system is not yet perfect, because I don't want us to think that, oh, they are doing, and I don't want to create a false impression of what we're doing. But we're definitely using digital tools, because in this day and age, if you do not use digital tools, I don't think that you can have a seamless process. But for the registration, for example, it has helped us to streamline the process. We're able to, we appear more, transparent to our providers, because you can see for yourself if you actually meet the requirements. Even the app, the portal would refuse some of the things that you try and upload. You will not be able to move further. And unfortunately, we have had so many instances of and it also peaks when one person has already uploaded one document, for example, your practicing license. If you upload it, and if you're unfortunate that you are the owner of the practicing license, if somebody just picks up your practicing license and uploads it before you are unable to use it. So you'll not be able to continue with that registration process until you come to, those are the instances where you have to come to the agency to try and resolve those issues. Yes. And then we also recently introduced what we call the QR code at the health facilities. It's still at the pilot stage, so we're still distributing, but some facilities have these QR codes now. So it's also enhancing transparency. And what the QR code does at the facility, one, it helps to, of course, once you see the QR code, you know that the facility is registered. But then it will go further to tell you who the operating officer of that facility is. So you know that it is not faceless. The operating officer has an identity. Two, you would know the scope of service, which is very important. You have clinics carrying out surgeries when they're not supposed to. So if you interact with the QR code, it will tell you this facility is registered for XYZ. So you know it is at your own peril. If you see that there is no surgery on, for example, the scope of service, and you still want to carry out surgery in that facility. And then lastly, it will also give the client the opportunity to give feedback. So if you're happy with the facility, you give a good feedback. If you are not happy with the facility, or you think that the facility has not provided good quality, you give the feedback, and we get the feedback at the agency. So basically, those are the three little things we're doing in trying to use technology.
I think we should give a round of applause for this. This is very insightful. Thank you very much, Madam PS, for giving us this update on what, how Aphpn has been able to harness digital technology in, becoming more efficient at what they do. Thank you. And then there's also a point that was made that we need to emphasize always when we talk about digital technology, that it is not supposed to replace humans, but only to complement what we do and to make us more efficient and to give us a greater reach. So thank you very much once more for that. I will be going now to the representative of Oncopadi Technologies. Your name again, please. Aminat, okay. So Aminat, this morning, we would like to hear about the amazing work that Oncopadi is doing in brief. We learn that you are using digital tools to support cancer patients. And I'm sure everyone in this room would know that cancer care is very challenging in an environment such as ours, with late diagnosis, a weak health system, and also care being very expensive. So it would be very helpful to us to understand how you are using technology to make a difference in helping these patients do things like get faster care and to stay connected with their providers.
Thank you very much, and good morning again, everyone. I'm stepping into big shoes today. My name is Aminat Abolade, and I'm the Chief of Staff at Oncopadi Technologies. And just to give a bit overview of the cancer ecosystem in Nigeria, every year, over 127,000 Nigerians are diagnosed with cancer. We have less than 100 clinical oncologists serving a wide population in Nigeria. Another weak link in cancer care in Nigeria is the underreporting of side effects. And this is because when patients present late, they don't even report the side effect because they're coming from different locations in Nigeria to come to the very few cancer centers we have. And more than 70% of cancer patients in Nigeria present late. So what are we doing at Oncopadi? One, we want to put the right tools in the patient's hands. We want them to make the right care right decision. We want to empower healthcare providers and also healthcare organizations to make confident cancer care decisions. And how are we doing this? One, we developed the OncoScreen tool. What is the OncoScreen tool? OncoScreen tool is for every body in Nigeria. You can easily put in your basic information, your age, your gender, and it will tell you your risk of developing cancer. And this was developed using the NCCN guideline. Another tool we have developed is the Oncopadi app. Now, this is our award-winning app, and what does it do? It helps every cancer patient to connect with specialists from across Nigeria. And this year, I would also love to share that we have partnered with the National Institute of Cancer Research and Treatment, NICRAT, and also Roche Pharmaceuticals to develop a national access program. So what do? We develop a digital navigation platform because we understand that the healthcare system is very fragmented, one. Two, it is very hard for an average Nigerian to navigate the healthcare system going from one doctor to another. We now developed a platform whereby we have online navigators to guide these patients. And I can successfully say that we have navigated patients from across 11 states in Nigeria down to the remote areas in Kebbi. We are able to provide them with free immunohistochemistry testing to improve their chances of treatment. Now, one other technology solution I'd love to share is our POST app. Now, PostCare is the first African validated digital tool, and it is developed with the post-CTCAC. And what does this tool do? It helps to we developed a remote symptom monitoring platform that is currently used across 3 national hospitals in Nigeria. And this platform helped a cancer organization to see for patients to report their side effects. Because what usually happens is that patients see their doctors on Monday, the next time for their side effects clinic is the next Monday. But the truth about being on chemotherapy and radiotherapy is that cancer treatment is very toxic, and a lot of these patients have side effects even in the middle of the night. It helps this patient to report their side effects in real time. The doctors get the feedback. Another important thing this tool does is that it triages these symptoms. Is these symptoms mild? Is it moderate? Is it an emergency that needs urgent attention? And we develop all this to ensure that there's increased access to cancer care in Nigeria. And we're bridging this gap. Thank you very much.
Wow. Thank you very much, Aminat Abolade, for giving us an overview of how Oncopadi has, embraced digital technology and is using this to enhance cancer treatment for Nigerians. She mentioned several tools, the OncoScreen tool, the Oncopadi app, partnering with other organizations, and the PostCare app. I think this is really commendable. I'll come back to you. Let me go back to Dr. Oyetoyo because I'm not sure how much time we have left for the panel, but I want to get at least one more question into each of our panelists so that we can, make this very robust. So for Dr. Oyetoyo, let me ask a question about the grassroots. Because you are in the health districts at the primary health care level, you get to relate well with the communities. You are the first port of call. What would you say from the little you've done with digital tools and leveraging technology are some of the cultural barriers or social barriers towards our communities embracing some of these digital tools? For example, things like telemedicine. What would you say are some of the barriers, and how do you think we can overcome them? Thank you.
Yeah, thank you very much once again. Thank you very much once again. I think
to the system, trust of the system, because that's another issue.
Okay, thank you, ma'am. I think to some extent in Lagos State, the digital penetration is still very high. compared to other states. That's compared to other states in Nigeria. Probably we may not be there yet. So that digital awareness is still much higher. Sometimes ago, I was opportune to be part of a group that wanted to start telemedicine about a decade ago. And what you just answered now was what actually killed that organization, because that acceptance was not there. And we also had issues with how do we ensure quality when you are consulting over an app. How do you ensure quality? How do you verify the health workers' eligibility to see a patient to start with? So we had that issue, and the organization eventually died. However, I think, just as I've said, to a large extent, that digital awareness is there in Lagos State. However, we still have to, if we are going all out for digital health, we must carry the community along, because the community might decide to reject it if we don't explain to them the benefits to a large extent. Okay, for example, we're about to roll out using QR code for like an exit interview. You just scan, and then it brings out Google form, and then you answer questions, and then we see it at the back end, and then we notify the facility that you have A and B complaints about you. However, before we roll it out, we want to have meetings with the World Health Committees, the local government health authorities. We want to have meetings with community-based organizations, so that before we roll out, they are already expecting such innovation. So I think one of the things we in the health family, one of the problems we face with the community is because we don't properly carry them along when we are coming up with innovations like this. So, as I've said earlier, to summarize what I've said, Lagos State has high penetration of digital devices. Lagos State, the awareness is very high, so we should leverage on that. And before we roll out, we should carry them along. Unfortunately, what we do is we roll out first, and then when we meet roadblocks, we now run back and start carrying them along. Thank you.
Thank you very much, Dr. Yetoyo. Please give him a round of applause. So much from that response, and I'm so glad Hefama is here, because we'll need you now to take some of those issues up. But let me just make a comment. You said a lot about the community, that yes, we still need to do a lot about carrying them along before we can deploy certain types of digital technology. I appreciate that, but we need to realize that the world is changing in its approach of deploying innovations. The community needs to be involved from the get-go. In fact, abroad, you can't, in a lot of climes, you cannot carry out research or implement a new strategy without end users being involved in the design. So we need to, go that route. It's also interesting that you're thinking of other innovations in Lagos State, such as the QR code for an exit interview, which would definitely be very important in quality control. It would serve like a digital exit table. So I'm very glad to hear that. Thank you once more, Dr. Itoyo. So coming back to you, Ma, the Permanent Secretary of HEFAMA. I will start from what Dr. Itoyo said and go into another question. This question has arisen in other fora, that if we've had pockets of telemedicine, especially from the private sector, and also from, the states. But how do we regulate to know who is doing what? Even for people who are doing telemedicine from abroad, there have been these questions. You have some, professional on the other side. How do we know who it is? How do we enforce these things? Then what research? Well, I think the issue of research is not in this question. We're talking about regulation, really, concerning telemedicine especially. And this brings to the other question that some technologies evolve faster than we can handle. So on the other side of the benefits, how do we ensure that we don't run into an area where patient safety becomes compromised, even in the issue of data protection and privacy, when we talk about leveraging or putting in digital tools? So I think that's a two-in-one question, but they are together.
All right, thank you very much. I had made up my mind that I was going to talk about telemedicine, even if you didn't ask me. So telemedicine as a branch of medicine is the most difficult branch to regulate because it doesn't have boundaries. It's virtual. We have guidelines for telemedicine, and we have a few providers registered with HEFAMA, but we have a myriad of providers that are not registered, and they are very difficult to, get hold of because that space is, there are a lot of actors, there are a lot of players. You have the telcos, you have Federal Ministry of Health, you have Medical and Dental Council of Nigeria, you have the federal government itself. You have the Data Protection Act and privacy or something. So there are a lot of actors, and a state actor cannot alone regulate that space. It has to be something that is, the collaboration and the determination of Nigeria as a whole to say that you are going to regulate that space. We have many people, consulting patients from India, from England, from the USA. But we as physicians in Nigeria, you cannot do that. It's not possible for you to, you want to do telemedicine, you want to start consulting a patient you cannot. It's not possible. So it must be the decision of Nigeria. We're in discussions. Yes, we have started having discussions. I know we were invited to Abuja at a point in time, the Federal Ministry of Health, to come and discuss guidelines because we already have guidelines and they are drafting guidelines. And I'm aware that a lot of work has been done. Some of the guidelines have been passed to the Senate, as a draft bill, and we're eagerly waiting for it to be, passed as a bill, not as a draft now, but as a bill, so that there will be active regulation of that space. We're saying so that innovation will not be adverse. One of the things we need to do to ensure that innovation is not adverse is also to continue to emphasize the place of, that you cannot rule out the place of human beings in ensuring that quality is, that you have quality in the healthcare space. Yeah, you would use your technology, but you would also, carry out whatever you as a human being is supposed to do in terms of providing healthcare, in terms of consulting, in terms of diagnosis, that place of intuition of the human being, you cannot rule it out. And as an aside, when you mentioned Onkopad, I was going to say, are you registered with Lagos State Government? Okay, thank you very much.
Thank you very much, Permanent Secretary of HEFAMA, Dr. Abiola Idowu. Very, very insightful feedback there. And well, those of us who are preparing the communique, please, there are things we need to put in there already for action. One of them is to push for the bill for active regulation of telemedicine. I think there are one or two others that we have that have come up as we spoke. So please, let's catch these things so that, like I said, this conference will be very impactful, and we'll come here next time to see the progress that we have made. Please, ma'am, I'm going to ask you one more question very quickly before I come to Uncle Paddy. In terms of regulation in Lagos State, we know that both the government and the private sector are major players in the state. So how can, what are the, first of all, what are the major challenges faced in, the synergy between government and the private sector? And is there any way we can leverage on these two organizations that have very different focus, very different modus operandi? Is there any way we can leverage on these two sectors to improve the adoption of digital technology? So this is just looking at the divide, so to speak, between public and private, and seeing how we can leverage on both for more synergy.
Okay, so, for in leveraging with government, what we have as government, even though we have we also have the technical know-how, but there are sometimes bureaucracy and wanting to fall in line with all the processes of government sometimes slows things down. So government can bring the arm of enforcement at all times, whilst the private sector, because they are usually very effective, they can bring in their technical know-how to streamline the process. Yeah.
Okay, thank you very much. Very short and simple, but I think we get the point. So each of them has their strengths, and we should, let each person play its role more effectively so that we can get the benefits from each sector. Thank you very much. A round of applause, please. Thank you. Thank you. Okay, so for, time, we need to wrap up now. Okay, then. Thank you. So, do we still have opportunities for one more question? Or maybe I should just open the floor for questions. Okay. So in wrapping up the panel, before I take questions, I want to thank each of our three speakers for bringing a lot of insight into this issue of, leveraging digital technology. I think we need much more research in this area, and we need much more interaction with the communities to be able to know how they would like us to meet them. That is, of course, the the demand side. Okay. On the supply side, we've heard about regulation, and we've heard about standardization. So please, let's give our three panelists a huge round of applause for bringing their A game today. Thank you very much. So before we go, we would like to take a few questions from the audience. We only have about 10 minutes, so maybe 3 questions, please. 1, 2. So 1 at the back, 2. Any other person? All right, we have 2 questions. Please, can you help us to? Oh, 3. Okay. So I have 1, 2, 3. All right, please, who is with the microphone, please, to help us with the questions? Please, let's know, introduce yourselves, please. Kindly introduce yourself before you give us your question, and make your question short and sharp. Thank you very much.
Okay, thank you. Good morning. I'm Doyo Dubanjo from the Nigerian Academy of Science. Good to see and hear the speakers. Thank you very much. One question for Dr. Oyetoyo. Are you looking into using AI-driven apps and things like that for diagnosis and therapy at the hospitals in Lagos State? Because what you presented was a management tool, really. So I just wanted to know that. Number 2, Dr. Edo, good to see you. And I was also wondering, how do you go about evidence-informed policy making? You know, what process? Because you have to go or basically formulate several policies in this regard. And in all honesty, like you've rightly said, I don't envy you. It's a very difficult space. But generally speaking, how do you go about ensuring that your policies are evidence-informed? What process would that take? Thank you.
Thank you very much, Dr. Dubanjo. Dr. Dubanjo is a past chairman of Aphpn Lagos chapter. Please, let's give him a round of applause. Next question, please, quickly. Thank you.
Good morning. My name is Dr. Folashade Fadare, MD Average General Hospital. I want to appreciate the panelists for the presentation, and the topic AI in health sector is very apt. But I want to say, how will the regulation be? Because once it's in the public space, everybody say all sorts. The one that want to treat hypertension, we say that his hypertension drug is the best. How are you going to, or how will it be possible to regulate people that in the corner of their house, they are saying this medicine can cure all, and we are encouraging everybody, oh, you can use AI. And we have so many people now that are in their room with their pajamas prescribing. Thank you.
Thank you very much, Dr. Fadare, MD of Harvey Road General Hospital. Yes, the next question. I think I have 2 here, so you make it quick.
Thank you. My name is Bisola Adebayo from LASUCOM. I want to thank the presenters. It was very insightful, thought-provoking, and it's showing direction of where we should be going to. My question is directed to Dr. Oyetoyo. I enjoyed your presentation, both the first one and during the panel, but I have some key questions. In terms of operationalization, what do you do about, first, challenges of power, and for it to work, you must have data, because all your staff that are using the platform, is it on their phones, personal devices, or do you have devices for them? So I want to know, do they have to use their own resources to keep the system going? And I also want to ask for the spectrum, is it end-to-end, like including prescribers, consultation, medical records, lab? So how does the system work? Is it based on like an EMR system, and then do you have devices that they use? Who provides data? Is it working 24 hours a day, even for people on call and all that? Thank you very much.
Thank you, Dr. Adebayo. Dr. Okatu, very briefly, because you are the MC.
Thank you so much all for your insightful discourse. Lagos State is doing a whole lot, but there's a lot more to be done. Dr. Adebayo covered some of the questions I wanted to, because I also wanted to ask if this covers individual service areas, you know, like you're trying to monitor vaccination and stuff like that. It's also good for QC, for quality control, like you're monitoring errors in the system. Is it that robust? I would also want to suggest that you can add some of these things into the system. for Dr. Ido. I remember in Qatar when our facility was going to be accredited, in addition to saying upload your licenses and all of that, they said you have to do certain trainings. And it was there in the Primary Healthcare Corporation platform, those vaccination trainings, mandatorily. We all had to go on the platform. So when we're talking about our licenses, CMEs, rather than time off to go for, there are registered, CME-worthy courses on the platform that healthcare professionals can also take on the platform. The certificates are there. You can verify it from there that these people have taken this training. So these are some things that I wanted to mention. Then I also wanted to mention, in terms of telemedicine, we can actually include diaspora engagement in telemedicine. If you have an app, LASU's alumni, LUTH alumni can come and lend their expertise here, such that people remotely, of course, there needs to be an infrastructure to do that. And then for people who have money, I remember working with IOM, one of the things that upset me the most was that our chest x-rays were being interpreted remotely because there are teleradiology centers where you have maybe 200 radiologists interpreting right there. Of course, it requires a lot of infrastructure, but it's something that I think we need to look at, such that even facilities that don't have can upload their images remotely. They are interpreted real time, and sent back. Thank you.
Thank you very much to our panelists and the audience too for the excellent questions. A quick question for Dr. Oyetoyo. You talked about, or you mentioned that you erase all records of the conversation between the patients, the doctors, and the consultants or the specialists at the secondary healthcare level. I'm just wondering, in this era of litigation, shouldn't we be considering some form of record keeping so that we can provide evidence of what was done, what was not done, what was discussed, and all of that? Maybe you might want to shed a bit more light on what you're doing in that direction. And then lastly, this might not be for you, it could be for everybody. Are we considering the use of drones, for instance, for delivering medications, especially for hard to reach areas in Lagos and beyond? Is this something we're thinking of? It'd be nice to hear your perspective. Once again, thank you.
Thank you very much for all your questions. So I'm now going to hand over to the panelists to respond one after the other. Yes, so where do we start? Okay, Dr. Yutonyo, back to you.
All right. We end with the police. No, she would end by regulating us. All right. So to start with the question of my chairman, my former chairman, Dr. Dubanjo. What we are presently doing, we are just starting to think of incorporating AI into what we are doing presently, and in the area in which we want to use AI is in predictive analysis for facility operations. Over time, the data gathered, AI will analyze it, and we can predictively say that if usually the range of patients that go to a XYZ PAC has dropped, AI can flag it off for us to know, to start asking questions, what is going on. However, for diagnosis, we have not started doing that. I also want to quickly say that what we have done so far is we just tested the waters. We are not there yet. We have a lot of grounds to cover too. And I think maybe I did not mention that while I was making the presentation, and that is why I have so much barrage of questions at me. We are still moving on. And as we one of the interesting things in management generally is that when you start a solution to a problem, you start seeing problems coming off from it. So we're in that stage now. Dr. Adebayo mentioned the tools that we deployed are completely different from EMR. EMR in the PSC in Lagos State is in partnership with Thalamus, and it is deployed in some selected facilities in Lagos State. And as you have mentioned, we also have that challenge. One of the challenges why EMR is still yet to be fully successful in Lagos State is some issues you raised. Issue of availability of gadgets, issue of data, issue of power. We still have that issue in the innovations that we've deployed. And to answer your question directly, as we speak to, let me say, 50-50, our health workers still use their devices to make sure this is operational. So the MC mentioned if it cuts across all services, not yet. We still use it for a limited service, mainly labor services and delivery services, and some emergency pediatric services, mainly for now. Because you know that this also cause additional work to consultants in secondary facilities. So we have to find a way to balance the two. So concerning issue of diaspora, I think that's a very great idea. And we have not just, because when she was mentioning only alumni of medical schools. We have people that are not even, maybe they are into tech in UK, Russia, even Russia, anywhere. We can invite them to look into what we are doing, make input, and help us grow. So the issue of data that we erase, they are mainly video data that we erase. Because we are not sure of the security of such data, so we prefer to erase it for now. When we are sure of the security, because we need to also work hand in hand with Ministry of Innovation, Science and Technology, and when we have that green light that we can store such in a secured environment, we can start doing that. And then the issue of using drone, honestly, I've not thought about it, and I think it will go a long way to, I think a farmer can borrow a leaf from that, because I know Lashma can borrow a leaf from that, because I know Lashma has issues with deploying drugs to some patients, and I'm sure patients will be happy if they get the drugs at their doorstep via drones. Thank you very much.
Please, a round of applause for Dr. Yetonyo. And before we come to Hefama, I would like to give Uncle Paddy an opportunity to say what their perspective about drones.
Thank you very much. But before I go into the drones, I'd love to answer the question about misinformation with AI. And I would love to say from our experience, one of the ways we have fought misinformation is through patient education. We have to empower patients with information to make the right decision. And one of the ways we did it is through support groups. So at the bedrock of all our technology, we have cancer survivors in our system. Now, when I talked about the access program we developed in NICAT, the only way we're able to penetrate remote areas in Kebbi, Taraba, Jalingo was because patients themselves go back to their community and be like, oh, I had this situation in my breast. I have been cured. Here's how you can be cured too. So one of the major ways we can actually fight misinformation is through patient education. We have to take time to educate our patients. That's why we all love Aphpn Doctor lately. He has actually done a massive misinformation tackling in Nigeria, and it's also a thing that we as healthcare provider have to take on that decision to actually educate our patients, educate our neighbors, let people know this is the right thing, because the truth is misinformation will always be there, even without AI or no AI. Thank you. And with the issue with drone, it's a very tricky situation because yes, it is very innovative, but looking at Nigeria, we have insecurity issues. What are the regulations in place? How can we ensure that these drones are not hijacked? How can we be sure that we have enough infrastructures to support the drone technology? So that is actually my question. So I think I'll throw it to my permanent secretary, Ma.
Thank you very much for your, Aminat, for the, your responses. They have helped to enrich us also. Thank you. So now we are going to wrap it up with our regulator. So the permanent secretary of HEFAMA, please, we want to hear from you, your feedback. Thank you.
Thank you. To Dr. Odubanjo, yes, evidence-based. We collect evidence during monitoring and inspections. We analyze the reports that we get. And then apart from that, we carry out researches. Currently, we are carrying out 2 researches. 2 years ago, we carried out research on infection prevention and control. And we're able to utilize that information to improve our tool and also engage with the Association of Infection Prevention and Control in Nigeria. So we carry out researches, we carry out studies, and we analyze our reports. To Dr. Fadari, yes, you were still all talking about regulating like either telemedicine or just providing care without actually seeing the patient physically. So it's when we're able to tackle regulation of telemedicine and mobile health as a whole, we'll be able to tackle that. Because, for example, if the telcos are involved, you will not be able, there will be certain messages you cannot send if you do not have approval to send it. So it's because the telcos have not been adequately engaged. And we can only engage telcos, well, through the federal government. And you, I cannot remember your name, but you mentioned something about alumni and people, like providing, it's all providing care. Alumni who are not registered with Medical and Dental Council of Nigeria, registered in the sense of having a current practicing license. If they are not allowed. They must be. You must register with MDCN or Nursing and Midwifery Council, wherever you are, before you can provide service. Before you can even to do what do you call it? All those X-rays and things like that. If we as a farmer, we do not allow it. If we know, we penalize, because those people must be registered adequately. If you cannot do it, if you cannot do it abroad, You cannot do it in Nigeria. You cannot do it in Lagos State.
Wow. Okay. Dr. Itoyo has. Okay.
Thank you. I want to, just thinking now, I think there is need for us to have, since we have the academia seated here and well represented, there's need for us to start doing independent studies that will help us improve on the operations at our own end, so that we will not have disjointed studies research. We have told you what we are doing. We need independent, objective bodies to come and see what we are doing, carry out research, and so that we can improve on what we are already doing. Thank you.
Wow, thank you very much. Please, can we give a huge round of applause to this awesome panel? So much has been gleaned from this short session that we've had today. And I'm just going to, in summary, mention a few things. First of all, this is a call to Aphpn and to individuals and bodies within the group for research on some of the things we've discussed and will discuss today and tomorrow, to provide evidence to drive innovations in digital health. We also need to strengthen the community involvement, amongst other things. So at this juncture, I have to end and say thank you to each of our esteemed panelists. Immediately to my right is Aminat Abolade, representing the CEO of Oncopadi. Please let's give her a round of applause. I want to thank our esteemed Permanent Secretary of HEFAMA, Dr. Abiola Idowu. Please, can we thank her for making time to be here personally? We really appreciate your insights, and we look forward to greater cooperation with HEFAMA. And to Dr. Oyetonyo, who is the Director of Medical Services Health District 1. Please, let's give him a round of applause for letting us know the innovations that are taking place at the grassroots level. Thank you. Thank you very much, everyone, for listening and for contributing.
Thank you very much. With a round of applause, please let's appreciate Professor Olufulayo. She really moderated well. Thank you so much to all our panelists, and thank you too for listening and for your contribution. Thank you so much. So once again, we welcome you. This is the Biennial and Scientific Conference 2025 of the Association of Public Health Physicians of Nigeria, with the theme, Global Health Under Threat, Advancing Sustainable Financing and Workforce Capacity for Equitable Healthcare Delivery in the Global South. Well, right about now, we're going to shake the table a little bit. We're going to go for tea break, but we are going to go orderly. And some people have been asking me, please, where's the restroom? The restroom is just, if you exit through that door, there's just one door. To your right, you will see another entrance that has a direction to the toilet facilities. We have for the male and we have for the female. Please look at the door well. Female sign and then the male sign. Female, don't mistakenly enter the male toilets and males as well. So we are going to take it orderly. We're going to start with the first table here. Then we move on to the second table, then to the third table. I have Dr. Drojaye there that will be directing us. So please, distinguished ladies and gentlemen, let's have the first table. So we're going to go table by table. And of course, a scientific conference is a place where we network, where we greet each other. So this tea break session is also for us to greet one another. There are some people here that I've not seen in the past 2-3 years. Please greet one another, take pictures, selfie, tag it on it.
When the night was cold and deep, I could barely fall asleep. Then you whispered in my ear, child, my love will draw you near. Now the darkness disappears. It's a love that never ends. Every wound it softly mends. All my fears begin to fade in the peace your hands have made. You have turned my pain to song, taught my soul where I belong. Every trial found its grace when I saw your shining face. Now I rest in your embrace. What embrace? It's a love that never ends. Every wound still hear my every call. In the silence, you remain, lifting me through joy and pain. Love unending is my game. Forever in your light, I stand, guided by your gentle hand. All my fear has lost its sight. Forever in your light. Every shadow fades away in the calm of break of day. Now I'm walking in your grace. Every step a warm embrace. Every breath a softer make. Forever in your light, I stand, guided by your gentle hand. All my fear has lost its sight. Forever in your light. You have given me new wings, joyful hearts, the angels sing. Now I live to praise your name. Yesterday won't be the same. Now the stars begin to rise, faith reflected in my eyes. Every tear turned into mine. Forever in your light. Forever in your light. Forever in your light. Forever in your light. Every whisper calls your name. Every night it feels the same. I can't hide the love I feel. Even time can't help me heal. Only you can make it real. Falling like the rain again. Every drop remembers when your touch was all I needed then. Falling like the rain again. I keep dreaming soft and slow. Of a world we used to know. Every tear feel strong, even though it's been so long. Falling like the rain again. Every drop remembers when love was wild but never tame. Falling like the rain again. Every word you left behind echoes gently through my mind. I still feel you when I pray. Love don't ever fade away. Now the moon begins to shine on this lonely heart of mine. Every breath still says your name. Falling like the rain again. Falling like the rain again. I was sinking deep in shame, lost in calling out your name. Then you came and made me whole, set a fire in my soul. Now I'm free, forever told. You lifted me high, you set me free. Now I'm who I'm meant to be. All my pain you turned to light. You lifted me high tonight. Oh, every scar became my stumbled, when I cried, you were standing by my side. Every shadow, every scar couldn't hide who you are. Love still found me from afar. The gentle hand of love lifted me from high above. When I thought my heart was done, love reached out and led me on. In the quiet of the pain, you will whisper in my name. Every wound began to close, every doubt began to slow, till your grace began to glow. The gentle hand of love lifted me from high above. Now I see the morning sun. Love reached out and made me one. When the world turns cold and gray, you still guide my heart to stay. Through the dark you pull me near, wipe away each hidden tear. Now I walk where angels move, bathed in light and bound by truth. Every step is touched with grace in the gentle hand's embrace. still hear you by my side. Letters in the dust tell the story of our trust. Every line and every stain brings you back again. Time has worn the edges thin, but your voice is still within. Every page you left behind speaks the truth I cannot hide. Letters in the dust tell the story of our trust. Every line and every stain brings you back again. If I read them one more time, will your heart fall back in line? Or are they all that's left of you? Words that once were true. Now I fold them tenderly, let them rest in memory. Though the past has turned to rust, love lives in the dust. I was lost in endless night, searching hard for morning light. Every dream was torn apart till your love restored my heart. Now your light ignites my spark. Shine that light upon my soul, make the broken pieces whole. When the shadows start to stay, lead me back to brighter days. Through the silence, through the rain, Shine that light upon my soul. Shine that light upon my soul. Make the broken pieces whole. Make the broken pieces whole. When the shadows start to stay. When the shadows start to stay. Lead me back to brighter day. Lead me back to brighter day. All my fears have lost their flame. Since you called me by my name, I rise, my spirit whole. In your love, I find my goal. Forever named, forever blessed, forever know, your light upon my soul. Shine the light upon my soul. I was reaching for the past, hoping broken hearts would last. But the truth came shining through. Said there's more that love can do when the soul is born anew. This is where love begins, cleansing every trace of sin. Every tear turns into song, where the heart's been lost so long. Now I see the skies are blue. Every road leads back to you. Through the dark I learned to see what your mercy means to me. Love was waiting patiently. This is where love begins, cleansing every trace of sin. Every tear turns into song, where the heart's been lost so long. Every trial had its place. Every fall became your grace. Now I'm free to start again with your love that never ends. Now the sunrise warms my skin. I can feel you deep within. Every breath my soul ascends. We know where love begins. I see longing in the sky. Every star reminds of you. Every dream still feels so true. Even when the night is through. Whispers of the moon tonight, calling softly, pure and white. Every tear a tender tune. Whispers of the moon. Every road that brought me here echoed love and quiet fear. Though we drifted far apart, you still live inside my heart. In the dark, that's where you start. Whispers of the moon tonight, calling softly, pure and white. Every tear a tender tune. Whispers of the moon. Love remembers what we lost. Even time can't pay the cost. Every sigh, a sweet perfume. Whispers of the moon. Now the sky begins to fade. Dreams of you will never end. Every night I think of you. Whispers of the moon. Every color in the room feels like shades of hue and blue. Soft reminders in the air of the love we used to wear, painted everywhere. Colors of your name glow in every gentle flame. Though the years don't feel the same, I still speak your name. I can see you through the haze, like the warmth of summer days.
Tell us how the next session will go. Professor Akinyinka, we have a panel of judges here. We have our presenters, they are ready. So how are we going to go about it? Professor Akinyinka. Yes, she has gone to get some of our people to come inside. Please let us come inside. You can grab your tea break and come inside, please. While we are waiting for Professor Akinyinka. Professor Akinyinka. Okay, 1 minute. Okay. So while we are waiting for Professor Akinyinka to come and tell us how we are going to go about this next session, I know we have the hall will be divided into two. So we'll have some people facing this screen and some people will face the other screen at the back. You can go through. Do we have it? The brochure. We are going to have two groups. One group will face this screen, and then the other group will face the screen at the back. We are going to have about 5 presenters each. Each of the presenter will be given 10 minutes to present. Nothing more than 10 minutes, but it can be less than, but not more than 10 minutes. After the presentation, then we'll ask them questions and answer period for 10 minutes for Group A and for Group B. Afterwards, we are going to go for the poster session. So I would suggest that we do not have to carry our chairs or be bothered that you want to be in a particular group. You can just turn your chair to face this side or turn your chair to face that side at the back, the screen at the back. So we're still waiting for Professor Akinyinka to come and tell us how the session will go. For those of us just joining us, we are going to have 2 groups. One group will face this screen and the other group will face the other screen. We are not going to use the microphone so that we'll not disturb each other. So the presenters would project their voices. We appreciate the presence of the Permanent Secretary, Health District 4, Dr. Abimbola Bowale. Thank you, sir, for joining us. So, a round of applause for the number 1 female professor that I've seen that is very cute. Please clap for her. Thank you very much. So she will be telling us how this session will go.
Thank you. Dr. Odiyo, I've seen many cute professors. Oh, my guys are very cute. Oh. Thank you very much. So, welcome to this part of this conference. So, this part of the conference is the scientific part, which is us listening to the research that our colleagues have done. And I want us to please, when we start, to listen carefully and it's a time to critique, all right? But the critique is to be constructive so that we can all get better. That's the reason for this critique that we will be doing. And like Dr. Onire has said, we are going to be divide ourselves into two groups, Team A and Team B. So Team A at the first two front rows here, will face this side. Team B are the next two rows, which will face that screen on the other side. So when we are to start, all you have to do is just turn your chair at that time, right, to face the screen that you want to be a part of. Now, I'm going to call out our judges. Ushers, are the ushers there? I'm going to call out our judges so that the ushers can usher them. We have special reserved seats for our judges. Now, some of them are already seated there, but we're still going to acknowledge them because it's work they want to do for us, and we are so grateful for what they are going to do. And so, for Team A judges. So the judges for this Team A session will be chaired by our one and only Professor Bayo Onojole. Round of applause for my Oga. Thank you, sir. We are very glad that you accepted to do this for us. And then the second judge is my one and only as well, my cute professor, actually, Professor Ololade Wright. Please usher her to that part. Yes, thank you very much. Thank you, ma. And the third judge for Team A is Professor Bola Balogun. Please help me give her a round of applause as well. Thank you very much. Right, so we'll give you all the things required for assessment. So on that table, we also have the repertoires and a timekeeper. Timekeeper for Team A, please wave your hand so we know who to hold. Timekeeper, your name, ma? Dr. Serrano. I know you. I know you. So Dr. Serrano is our timekeeper for Team A. Thank you very much. So Team B judges. So Team B judges, the session will be judged and chaired by Professor Odeyemi. Please help me give her a round of applause. Thank you, ma. We appreciate you, ma. Okay. And then the second judge, she'll be supported in these judging duties by, I'm sure I will say our one and only again because I don't know another one in Ministry of Health. Right. So Dr. Abdul Salam, please. Thank you very much, sir. Okay. Right. So the third judge for Team B is, and this is all the way from Lasu Ojo, Dr. Nasir Aribi. Thank you very much, sir. We appreciate you, all all of our judges. So we will give you the assessment sheets, our judges, and if the number does not appear there, please just cross it out and write out the number, because each presenter has a session number. So I'm going to read out the session numbers for Team A. So those that are going to present, that's the abstract numbers. Sorry. So timekeeper for Team B, please, can you wave your hand? Timekeeper for Team B, Dr. Odufua. Please give a round of applause too. So you have to go to Team B. You have to go down there. Please usher her there. Thank you. Right, thank you very much. So if you are a presenter, presenters, oral presentations are going to start. So please listen to your abstract number. So presenters for Team A are those with abstract numbers that end. The abstract number is long, Aphpn 2025, and then ends with 3 digits. So listen to the last 3 digits. So for Team A, your abstract numbers are 002, 003, 010, 011, and 0112. Right, so if you, for Team A, you can actually come and sit here. If you are presenting for Team A, since we have chairs here, you can sit here and then you come and present once it's time for you. Here, you want them to be here, okay. So presenters with those abstract numbers, please come to this table. And then presenters for Team B are those with abstract numbers 015, that's 15. Right, so for Team B, 015, 016, 018, 020, and 024. So that's 15, 16, 18, 20, and 24. So please move over to the table down there. Dr. Oniire is pointing to that table so that you can sit down close to where the screen is so you can make your presentation. Right. So each presenter will have just 10 minutes. And our timekeepers are going to keep strictly to that time. Right. So they are going to give you warnings. Presenters, please pay attention. They are going to give you warnings when you have spent 5 minutes. They will warn you. When you have 2 minutes left, they will give you a warning. And then when your time is up for that presentation, that is. So when you have spent 10 minutes, they will also give you a warning. So this is like a mini exam. Our assessors are going to be, our judges are going to be assessing. So please keep to time so that we can save our time, and you can give us the critical issues that we need to know about. Then apart from this, the judges are assessing everything about you, all right, for this presentation. So please present well. Thank you. Then once the 5 presenters are done, or 4, depending on how many people are presenting on each team, right, then there will be a question and answer session immediately after all presentations have been taken. Right, for each of the teams, there will be a question and answer session, which is just for 10 minutes. So if you have listened well and you have questions, then you will then ask those questions. So please, during the sessions, Please just note down your questions because the sessions will be back to back. So after one presenter, the next one will come and then the next one. So please write down your questions so that you don't forget, right? So that once it's Q&A time, you can then ask your questions and the presenters can answer. Right, are we good? Okay. Are we good now? Are we good now? Okay. 002, 002, 003, 010, 011, and 012. So that's 3, 2, 3, 10, 11, and 12. So you don't have to walk too far. So presenters, please, you will not use the mic because this is just one hall and we have not demarcated the hall into two. So you will have to project your voices to make sure that your audience, so your audience is made up of the first two rows and same thing on the other side. So you project your voices so that the audience can hear you, right? And so that we can understand the research that you have conducted and will be able to benefit from your findings and implications as well. Right. Okay. So, are we good now? Dr. O'Neill? Dr. Drojai, do the judges have their assessments now? Okay. All right. Okay. So, are we good? Okay. So, now that we are settled, for those on this side, you are facing me already, these first two rows. So you don't need to change, turn your seat. But for those on the last two rows there, please turn your seat so that you are comfortable. You are facing that screen. So please turn your seats. If you need assistance, please just call one of our beautiful ushers. They will assist you to turn your seats. So please turn your seats if you are on the last two rows. What of the one here? Okay, so please turn your seats, those on the last two rows, so that you are facing that other screen. Right? And if you want to be on this side, then you can come closer. Because if you are far away, you may not hear because they are not going to use the mic. Okay. So are we good? So all presenters are settled, right? Presenters, yeah, okay. Presenters, yeah, okay, okay. Presenters on the other side, are we good? We are good. Okay, so let me hand over to the chairs. So the chairs of the sessions will then take over from here so that we can have the sessions. Thank you very much. So we can start. You need the numbers. I think you will need the numbers, but they are written. So
by gender, again, females, I already mentioned why. Then age group is 18 to 45, which was the main age group of enrollment. And then for marital status, mostly single people. Sorry, then for utilization. Now, one thing about utilization is it can be positive, it can be negative. So positive in the sense that when people utilize the skill, it means that they trust the skill and they trust the service that they're getting from the skill. But when they utilize beyond a certain level, they were talking about adverse selection or moral hazard, and the case may be. But here, we're saying that for people who visit the physical groups, I mentioned the virtual physical access centers. So we have a 15 minutes wait time, and the utilization was about 1,204 people total that access services there. So we have average BP check of 125 and 80 millimeters of mercury when we're checking for all the 1,200 people that visited. And of course, the gender selection was mostly female again. They are the ones that more, they tend to have better health behavior, they tend to look after their health and check what is wrong with them and what they can do. Then most for reasons for visitation for vital checks, they check their blood pressure, check their glucose level, only 22% actually came for medical consultations. Okay. Then for the common diagnosis, high blood pressure. That's hypertension. For most of them, they were not diagnosed, that's well known. For some, they were already known hypertensive. Then you have 24% for febrile illnesses for many reasons. Malaria, active respiratory infection, and others. Alright, so then the hotline, we have 59% women using the hotline. We had 65 verified installation from the then the most common diagnosis is febrile illness, I mentioned it that time, operation tract infections. Then referral was managed in-house because each booth is managed by a healthcare worker who is trained to do referral from nearest healthcare facility. So in case they pick up someone with undiagnosed high blood pressure or with hyperglycemia, they can easily refer to the nearest healthcare center. And then of course, the referral is English for 9 hours. Then for mobile app, we had 3 minutes, and then average duration of control is 11 minutes. And of course, same thing, 25 39 was the highest, which shows that mostly young people are utilizing it. So this was people's perception about it. They said they used it to speak, shorten the time for them to access services. They don't have to wait for many hours in the hospital. And then because we use the marketplaces mostly, the market leaders they had bought into this idea. So it was easy for people in the market to actually use and access services in these physical centers. Now, basically what this is saying is that for you to do anything in any point, you need to ensure you have the buy-in of the participants staff. You have to speak to the leaders direct their followers, and when there's a buy-in, there's going to be a So, now what are the next steps? We show that virtual booths actually reduce waiting time in hospitals. When there's no need to use physical facilities, we need to do that. It gives access to healthcare very fast, and then because of the also access to medical consultations, even when there's an emergency, there's an aspect of an emergency that this can actually take care of. And then we also made it very easy in terms of targeting certain people, where if you want to enroll into the plan, you have options of paying until you complete your payments. So thank you very much. Thank you very much, President. You can have your seat. Presenter 003. AI-based game for enhancing HPV awareness and prevention in Nigeria. Basically, HPV is a major public health issue, and it causes over 100% of cervical cancer. So it causes over 100% of cervical cancer. So what my team and I did is we developed a HPV game, which is called 90% Shield. It's an AI-powered game. So basically, WHO said that they want to achieve the 90%, 70%, 90%, whereby there will be 90% vaccination, 70%, 90% vaccination, 7% screening, and over 90%. So basically what we now did was that we used the name of the 90% to create the HPV platform called 90% Shield. 90% Shield is a generative AI platform which is built basically on lovable AI, ChatGPT, DeepSeek OpenAI.
Not that one.
Let's go to the aims and objectives. Aims and objectives. So basically, HPV is a major public health issue that causes over 100% of cervical cancer. So we decided to create a novel project called the 90% Shield HPV Warrior. It's an AI-powered game that was developed over a period of 8 months, whereby we decided to create it based on the fact that we want to promote vaccination, HPV knowledge, and preventive behaviors among Nigerian youth. So the methodology we achieved was we used a mixed method design whereby it was experimental where we developed the game for 6 months. So we involved oncologists, we involved basically AI engineers into the project, and we involved also public health experts into the project. So the game was developed using the front end was developed using novel AI, ChatGPT. It has an AI assistant that is based on OpenAI, and also the back end framework was developed with Python. And basically we use a super-based framework for the back end. So now we ensure that after developing the game, we ran the first pilot phase whereby we recruited 20 youths, and we started 20 youths over Nigeria where we got online and recruited them from the study. And we ensured that the people who were involved in the study didn't have the prior knowledge of HPV vaccination, and we included both males and females in the study. Now these are results. We successfully was able to design and implement the generative AI-based game because the game had a few features of HPV. It does not only work for basically English, it has a multilingual helping function whereby you can use it for Yoruba, you can use it for Igbo, you can use it for Hausa, because we plan on launching this in 2026. Basically what we observed was that the fine-tuning was done with Cloud Gemini API, which was real optimal function. It has basically 9 games, which span whereby we assess their knowledge and improve their behavioral. So basically, this is a pre and post-intervention assessment. So for transmission, HPV transmission and risk, pre-test mean score was 42.3%, while post-test mean score was 91.8%. It showed that there was an increase of over 49.5%. While HPV vaccination benefits and safety, 38.7% was pre-test mean score, while the post-test mean score was 93.4%. The cervical cancer knowledge prevention strategies was 45.1%, and the post-test mean score was 90.6%. Now, generally, we observed that there was an increase between the pre-test knowledge and post-test knowledge of over 50.2%. Now, one of the things we observe is that participants from the project were able to identify, when they identified the primary cause of cervical cancer, pre-test was 34%, but post-test of the project was 96%. Then intention to vaccinate within the 3 months was 28% prior to the project, and it's 9% post-intervention. Now, objective 2, we assess the user engagement and satisfaction. Why do we assess the user engagement? We are using a novel project whereby it has not been done in Africa. So we included factors from research literatures we saw in Norway and the UK. And we observed that engagement metrics for the 20 players were average play time was about 5 hours, 42 minutes, over 4 weeks. And basically the average session per user was about 28.4. The completion rate of the main storyline was 94% because we ensured that it was culturally appealing. And satisfaction and accessibility. Overall satisfaction was 4.71 plus or minus standard deviation of 0.4. Now, one of the things we observed from the thematic analysis that was done is that one of the players reported that the game made learning about HPV more. We want to make health education well fun and educative in the process. So we're able to have 96% who agree to that factor. And we had another person saying, I would recommend these games to my friends. And so we take the feedback and then get the personalized storytelling, whereby the AI was able to generate personalized storytelling for the players. And it has an inbuilt 90% shift AI assistant, whereby we streamlined we didn't fine-tune the model, instead we streamlined the model whereby it's restricting you to ask questions specifically on HPV. So the demonstration of AI gaming. Now, if you compare the cost of the project, is minimal cost, whereby the infrastructure came from within the team, where we had people who were in the AI sector within our team. So now, the conclusion. A 9% should achieve dramatic improvement in HPV knowledge. That means there was an increase in knowledge from over 50.2% and shifted vaccine intention from minority to nearly universal, 28% to 59%. Now, this shows that public health education should be streamlined towards innovative projects. So, and this is a project that can be applied towards not only HPV vaccine, but can be applied towards cancer education, tobacco education, and sexual reproductive health. Thank you very much. mentioned that medical services are an integral part of social health insurance plan. So when you subscribe to one of the social health plans, you have access to services under intelligence. It is just there. So what we did was, because we knew that some people are doing these guys, and then for over time, solution brings about services. So we need to ensure that it's so utilization and
Okay, so this is to say thank you. We have not finished. We have not finished all of the assessments because there will still be poster sessions. You know, these were oral presentations, and there will still be the poster sessions where each person will then speak to their posters. And so we ask that our judges please bear with us. We'll have some other session before we then have the poster session. But right now, please help me give all of our judges a wonderful round of applause. And please give yourselves too a round of applause for being a fantastic audience. Thank you very much.
Thank you very much. And a round of applause too to Professor Akinka. Okay, so we are moving on. So we can all go back to our seats, but if we feel comfortable where we are, it's fine. Dr. Hello, can you confirm if Professor Akin is around now? Okay. So we are going to move on now, and we want to appreciate the presence of our professors here. We appreciate the presence of Professor Bayo Nonjole, Professor Roberts, our erudite former permanent secretary. When we came into the ministry, she was already a permanent secretary as at that time. I speak of no other person than Dr. Lola Gbe Davis. You are welcome, ma. And of course, we have here with us also a former permanent secretary and the chairman of the board at the Health Service Commission, our very own mama, Dr. Atinuke Onoiga. You are welcome, ma. We are going to move on now, and I heard that, oh yeah, we have one of our permanent secretaries also here. Dr. Cecilia Mabugunje, permanent secretary, I'm used to saying else District 6. She's no longer else District 6, please. Permanent Secretary, Health Service Commission, HSC. You're welcome, ma. So I learned that Dr. Shola Kwiton is around. Dr. Shola Kwiton. Dr. Hello, can we confirm if Dr. Shola Kwiton is around? Oh, okay. Thank you, ma'am. Okay. We are to have Professor Akin Oshibogun, but he's also on the way. He will join us soon. I learned that in the next 5-10 minutes, it will be here. So I think we will just go on with that session. Dr. Fadirima, do you have any news for me? Thank you very much. So while we are moving on, we realize that some of our very big people might not be here tomorrow. And tomorrow, we are supposed to have goodwill messages from all of them. So we are going to be inviting them to come and give us their goodwill messages today. So let me start by calling the Permanent Secretary, Health Service Commission, Dr. Abimbola Cecilia Mabogunje. You dare not come late to work with her. Number one Permanent Secretary that gets to work at 7:30.
Good afternoon, all. Good afternoon, Ma. Chairman, Health Service Commission, all our elders here, and colleagues, distinguished colleagues. I'm happy to be here. It's a good delight. And recently, I became a member of this public health association. Yes. I think public health is one of the specialties that is underlooked and not given the recognition it deserves. And the importance of public health is the collaboration between community, hospital, and everybody. And that needs to be emphasized and brought to the forefront. But I'm happy to be here. I am looking forward to our session, the panel session, and it's good to see everybody again. So happy deliberations. Thank you.
Thank you very much, Ma. So, yes, a pediatrician by profession, public health physician by yes. Okay, by association. Okay, so let me call Dr. Abimbola Bowale. When you call for a meeting, you will be the first to get there. He has done it before. We called one meeting 8 a.m. By 7:49, he was there. Dr. Abimbola Bowale, we are ready for your goodwill message. Thank you very much, sir. Permanent Secretary, Health District 4.
Good afternoon to the elders in the room. Good afternoon, everybody. I'm also very delighted to be in our midst today, knowing that this is a meeting of the gown and the town. So I'm hoping that the knowledge that will be shared here today will also benefit us who are on the field in the primary healthcare sector, so that we can have an improved and an enhanced quality healthcare for the people at the grassroots. So I wish all of us a very good deliberation. Thank you very much.
Thank you very much, sir. I love that concept. Taking the gown to town. Thank you so much, sir. So we also have here with us our own mama. I've known her since the days of Medical Women Association of Nigeria. I speak of no other person than Mama Onosonya. You are welcome, ma. Mosonya, you are welcome, ma. Thank you for coming. We appreciate you, ma. Healing with the love of a mother. That's Mama Mosonya. So let me invite to the podium right now the chairman of the board, Health Service Commission, for your goodwill message, ma. For your goodwill message, ma, just to greet us, Dr. Atinuke Onoiga. Ah, mommy, I want to be like you when I grow up, oh. Ah, you're welcome. Stay.
Let me comment on that. You'll be like me, and you'll even be better than I am. and you grow better. But be ready at my age to take some exercises that includes boxing as well to strengthen your muscles so that you don't have other things that will pull you down. But the Lord will exalt each and every one of you. Thank you so much. Well, whenever I'm called to give goodwill messages, especially in a gathering where I'm part of, and even though you don't see me tangibly all the time, but I can tell you that even without seeing me, my heart is deep within the concept of what public health stands for and is all about. So I'm very happy to be with you today, and I want to let you know that as they were doing the session, I was listening. I came in about like 2 or 3 before it ended. And right there where I sat, my question was, we talk, we hear, we do all the things we're supposed to do in terms of the scientific knowledge and everything that we have to do to actually get to the concept of where would we be going on the preventive level to save our community and give them the right thing for them to live healthily. But we never get to the threshold or the trust of doing it. And this is what I want us to go one step further in. Yes, we are gathered here today. We are going to say a lot of things. We need a mover. We need someone who can carry the ball, kick the ball, to actually let it get to the right person that will actually make this to become a reality, something that the whole nation can work with, and we can have a healthier nation than we have. So with this, I want to congratulate each and every one of us, and that we should start thinking that beyond the talk mentally, beyond the brains, beyond the researches, there is still some figment of it that is needed. Who rolls the ball to ensure that all of this are translated into policies that will be adopted by the nation for a healthier nation? Thank you very much.
Thank you, ma. Thank you, ma. So policies that will be adopted for a healthier nation. Yes, before now, we used to have one of our very own. He used to act as the MC, the compare of this conference. From MC to so you know who I'm speaking about? Okay, so I speak of no other person than our very own. Used to be MC, but now Permanent Secretary of Health District 1, Dr. Shola Bitson. We want to hear your voice. We want to come and greet us first. Greet us. You're welcome, sir.
Thank you very much. The chairman of today's occasion and the chairman and executive members of the Aphpn, for me, it's a pleasure to be here. I'm very proud to be part of this great association of public health physicians doing great work in various dimensions in Lagos State. I want to recognize the presence of all our teachers here present, all our medical elders. Thank you for all that you have incorporated and inculcated in us, in all of us. And I do hope that you are proud that we are keeping the flag flying, and God will keep helping us. Yes, it's okay. Please clap, please clap. I know that many of you are sitting there and you are seeing many of us younger ones. Here is one, here is another one, and many are still sitting in the audience too. I know that just like proud parents, you are happy that the torch that you've lit, we are rekindling the fire and we are making it grow. God will keep helping us. I look forward to an Aphpn conference that will be internationally recognized, that will have international attendees. Yes, please, let's clap. Each time I think about it, this is what I see, where we'll have scientific sessions, we'll have different poster presentations, and a whole lot more. And people internationally will come and join us. So hopefully in the next few years, we will have that. Thank you very much. It's a pleasure being here.
Thank you very much, sir. So we are moving on now, and next up on the agenda is to have a technical session on the overview of systemic reviews. This will be taken by Dr. Shola Pito, the Permanent Secretary of Lagos Health District 1. So, sir, let me read your bio. Dr. Adeshola Pito is the newly appointed Permanent Secretary for Health District 1, Lagos State, a public health physician with expertise in health policy and management. Dr. Pito is the outgoing medical director and CEO of General Hospital Lagos, where he served for 4 months. Dr. Pito obtained his MBCHP degree from the Olabisi Onabanjo University and earned a Master of Public Health from the Rolling School of Public Health, Emory University, USA. He is also a member of the West African College of Physicians and is currently pursuing an MBA at the Lagos Business School in view December 2025. He is a recipient of multiple transformational leadership awards from the Office of Transformation, Creativity and Innovation Service Charter 2022, 2023, and 2024, and holds certifications in quality improvement, patient safety, leadership, patient and family-centered care, and managing healthcare operations. Institute for Healthcare Improvement 2013 and 2019. Healthcare Quality and Safety, Harvard Medical School 2018. Leadership and Management in Health, University of Washington 2023. And Healthcare Management Program, Enterprise Development Center, Pan Atlantic University 2023. He is a member, American Public Health Association, member, American Evaluation Association, and member, Association of Public Health Physicians of Nigeria, Lagos chapter, amongst others. Distinguished ladies and gentlemen, I present to you Dr. Shola Pito as he takes us on the next topic, overview of systemic reviews. You're welcome, sir.
Good afternoon, ladies and gentlemen, once again. Well, I'm here to speak briefly about systematic scientific reviews. Some few years ago, I was opportune to be a fellow at the U.S. Centers for Disease Control and Prevention, and I was in a unit called the Community Guide Branch, one of the units that their role was to be the think tank for these systematic reviews to cover community-based healthcare programs and interventions being done within the U.S. They would present these findings, whatever findings they find after their effort, to the Community Preventive Services Task Force, which is a 15-man-led U.S. task force, who will now make recommendations for the entire country. So it's based on that research work that they will make those recommendations, and those recommendations are pretty binding, even up till the Supreme Court, if necessary. So I'm here to just provide just a few information about it, just to ginger. I know that many of us already know something about systematic reviews, but just on the methods. Now, I'm going to just be particular about the community guide systematic review methodology, but there are many other organizations that are involved with systematic reviews, and some of them, their methods are different. Okay, thank you. Okay, so only the one up? Oh, I pointed to it. Is it the down one? Okay. So I'll just give some basics on systematic reviews, and then we'll go into the community guide methodology, and we'll conclude. This first slide just gives us broad information about the study designs, the various study designs we have, and we see that in terms of the strength of the conclusions and how we view, as scientists, how we view those conclusions, we know that what we get from systematic reviews is, gives us a more surer confidence that whatever we are taking, the conclusions being drawn, when we implement them, we will be able to get similar results, all things being equal. This next one, of course, talks about the hierarchy of study designs as well. So we're familiar with these things already. I'm not going to spend too much time. I understand I have like 35, 40 minutes. So, well, systematic reviews, we know it's how we synthesize all the available evidence. We pull them together. We extract information from them. We analyze that information. We try to describe it. We critically appraise them, assess them, put that information together, and then try to draw some conclusions, and then present that information either, quantitatively or sometimes qualitatively, depending on the type of findings or studies that are involved. So, of course, there are different types of systematic reviews. Some like to subcategorize them. They all pretty much relate to the same thing, just a few differences. Scoping reviews, getting things from the existing literature. You don't do a quality of execution in scoping reviews. So just a few things separate each other. Of course, the meta-analysis is the highest one, where quantitatively you are extracting quantitative data from each study that you've gotten for that review process, and then you are combining and then drawing conclusions, either doing odds ratios or risk ratios. Then mixed methods is a combination of both the qualitative review that just gets qualitative information, and the one that does the meta-analysis. So it's a combination. The rapid review is something that can be used when we have outbreaks. So you don't follow all the methods through and through because you don't have the time. Actually, systematic reviews can actually be very, very time consuming. Sometimes, depending on the topic you are talking about and the number of studies available, it could take 2 years before you even finish the process because it can be very long, and so on and so forth. So why use the evidence approach? Is the responsible thing to do. Why should we bother ourselves trying to do systematic reviews and using the information from systematic reviews to take decisions? Is the sensible, responsible thing to do, because resources are not endless. So we have to manage our resources effectively and efficiently, use those resources. And then it's also the smart thing to do. You have to be able to justify how you arrived at your decisions, what are the evidence gaps that you see, and so on and so on. So it's very, very important that we consider systematic reviews in decision making for whatever policies or programs we want to do. Okay, then some of the benefits of systematic reviews is that you can be more confident in using them. You find that it's reliable. So instead of basing your policy decisions, intervention decisions, or whatever else you want to do on anecdotal information, what some people have done in this area, and they are reporting back to you, at least you know that you have this review that has talked about this intervention and has pulled information from various sources together. So, and then it has gone through a transparent process. So you know that there's minimal bias, because the methods are outlined and they have followed that method, and you expect that that's what has been done. So, and of course, you know that those decisions have been made based on the synthesis of all the available data, provided that they have followed the necessary steps. Okay. Next. So here are just some of the organizations, international ones, that have been known to conduct systematic reviews, and they use those systematic reviews to take decisions. WHO being one of them, and I think it makes sense because they take decisions that all of us in every part of the world do follow. So I think it's important that they use systematic reviews in taking their decisions. You have NICE, National Institute for Health and Care Excellence, that is UK-based. You also have the Cochrane collaboration, the one that is very popular that all of us know. It's also another UK-based one. Then you have ARC. It's a US-based one. There is the US Preventive Services Task Force. They deal with more personalized healthcare issues that are more clinically inclined. Now, this agency of the government, of the US government, is the one that does the job that Community Guide does. They have the scientists in there. They get all the sources about that issue. Take, for instance, there was a controversial one about the importance of mammography for women and the age. And at some point, I remember it became a national issue in the US because they came out with a recommendation, that task force, US Preventive Services Task Force, that there wasn't enough evidence to support that they should do it at a certain age, that it will be beneficial. So, and they had looked at all the available studies, they had looked at the economic consequences. And what they found didn't support it, and then they came out with that recommendation, and then the whole country went haywire. All the women groups went after the Health and Human Services Ministry, and a lot of controversy about it. So that's how important, because for that recommendation that task force came out with, it means that the insurance companies were not going to pay for anybody below that age group, for their mammograms. And we all know in the US, for instance, every test, every procedure is very expensive. So, it's not like here you pay 15,000, 20,000 for a mammogram. There you will pay a couple hundreds, if not thousands, just to get that mammogram done. So it was a big issue. And they felt that the women were being hard done. But the science just didn't support it, according to the process that they followed. So that's how important these organizations are. So we'll go to the community guides methods. Okay, now these are some of the organizations within Nigeria that are already involved in systematic reviews, conducting systematic reviews. So we have our own version of the Cochrane Nigeria. They are an associate group. They started since 2006, apparently. Then they have the Cochrane Evidence Synthesis Unit, which was established just last year. And then another one called Systematic Reviews Network. This is an association of different individuals, academics from various institutions in Nigeria. They launched it, I think, 2022 in Unilag. It was launched there. It doesn't mean that it's headquartered in Unilag, but it means that there are people all over. Then there is a group in UNN, Nsukka, that also is involved. The question is, and that speaks to my last slide, that, what are we doing in Lagos? Can we start something in Luth? Can we start something in Lasut or other healthcare institutions in Lagos State? It's actually my last slide. Okay, so the community guide formed in 1996. The whole idea was to have a group of a team that would look at evidence on various population-based programs or interventions. Broad topic areas, and then look for interventions that impact health that are being done, and synthesize all studies done on those interventions and try to make sense whether the evidence supports what's being done. If we're going to pump money as a nation into this program, will it be worth it for government? Will it be cost effective for government? Will it be cost beneficial even to the population? So they wanted to answer that question. So they formed this task force called the Community Preventive Services Task Force. And then they now embedded a branch of the US CDC that was to do all the heavy lifting, all the hard work and all that. So I just happened to have had the privilege of working in that unit. So that's how my journey in this began. So I'm saying that I'm not an expert in it, in short, that's what I'm saying. So these are some of the things that this was their goal, to try and make sure that information for decision makers was evidence-based and that they were not going to be wasting resources, essentially. And the recommendations they make is what decision makers all across the country ideally should follow. If you don't follow it, you're on your own, because it's a highly litigious society. Highly litigious society. So if you go and do something that is not evidence-based, at the end of the day, when they start dragging and it gets to the courts, you have no leg to stand on, basically. So, but you can actually cite the recommendations of the CPSTF task force and the USPSTF task force in the court, up to the Supreme Court, and you will have a legal standing to stand on. So this is a analytic framework. When they want to start the process, they think about broad topics. Let's say tobacco. What are the issues we have in tobacco? Let's look at drunk driving. So down each one of those, or violence, vaccinations, maybe immunizations and all that. They think about all those broad issues and then begin to look in each one of those broad issues. What are the challenges we have? What are the interventions people have tried to do? And then they begin to highlight. I'll give some examples here, and then I'll narrow down to something I was a part of and just use that to explain. So the overall one there, I don't know, does this point? Okay. The overall one there is the policy of the program, the population, the determinants, and then you have intermediate outcomes in the rectangles with the curved edges. And then you have the final intended outcomes, either in red or in this overall one, reducing morbidity and mortality. Now, for them, because most of this, they want for community guide, the CPSTF, is population-based program. They don't just limit themselves to morbidity and mortality prevention alone. They look at other things, behavioral outcomes, behavioral changes, and other health changes that may happen. And why? They know that ultimately it will help with reducing morbidity and mortality. Take, for instance, the example I'm about to show, quit lights, which is telephone-based interventions. So somebody is smoking and is willing to stop smoking, and then you want to help that person to stop smoking. This is all under tobacco cessation interventions. So it's a broad topic of tobacco, how to reduce tobacco use in the US. So now they thought about telephone quit lines, and they said, okay, let's look at all the studies that have done something about using quit lines, telephone quit lines, to help people to smoke. Now, there are other interventions, but let's look at this narrow one. And so when they looked at it, they said, okay, one of the things we want to see, how many people quit within the first 6 months, how many people took longer, and so on and so forth. So we'll get to some of those examples. So, of course, they look at the economic efficiency of all their reviews as well. It's not moving. Okay. So they do their rigorous systematic approach of gathering evidence. They consider all relevant sources of information. And I will get to some of that just now. They look at various studies. They do a Boolean search. They look at various databases. They will have come up with terms related to the topic area. All the terms that they can use that to put it out there and look at various search engines. And it would generate a huge, amount of different studies. So that's the starting point. But before then, they would have taken the first decision, which is, let's sit down. What do we want to do? What broad topic area are we focusing on? What intervention in that broad topic area are we focusing on? And then let's come up with a team. They call it the coordination team. So they come up with a team. They define several things, including research questions and so on. They define how and the methodology they want to use before they even start at all. So I'll highlight some of them. So why is this racing? He's running faster than I am. Okay, so let's go to this one. They prioritize topic areas. They recruit a multidisciplinary team for a prioritized topic. So, and they let the team cut across various interests because you want to capture various interest groups. Then they determine the scope of the topic they want to do, and then they prioritize the intervention they want to look at. Then, so these are some of the broad topics that we see, for instance, that community guide look at: obesity, oral health, physical activity, tobacco, violence prevention, asthma, cancer, and so on and so forth. Those are the broad topics. Okay. Then they come up with a coordination team. They have various categories of people. We were some of the fellows. You had other scientists. You had people who were now task force members. The task force members are people who are in practice. They work in county health. They are in academia. They are in various. They've done all of them. I'm sorry to all the elders. They have gray hair. So the gray hair is the wisdom and the knowledge they've amassed over the years. So when they are actually contributing, they are looking at several things. First of all, they've gone beyond the heavy lifting part. They've done it before. So there's nothing you're coming to come and tell them that they don't know. But they go beyond that. You are just stationed there in the CDC, but they are in practice. So they know how it will impact. Then you also have subject matter experts that are brought in. So if the topic is on violence prevention, then they are going to look at people who are in that field. They will try to co-opt some of those organizations into the system, and so on and so forth. So this just talks about the task force. It's non-federal. They are not paid. So I guess that's why they have that independence. So they are not collecting money from the federal government. They are working where they are working. So they meet thrice a year. Now, for what we are talking about here in terms of systematic reviews, we don't even have to wait till we have a task force. We can just form that coordination team, have a hub in one of our institutions, and bring people from various other parts of the academia, and in practice, I see HSC here, there's Ministry of Health, and so on and so forth, NIMA, and so on. Bring people together and then try to begin that process from there. And whatever we now come up with, then we can put it out there, and then when policymakers want to take decisions on any topic area, they can refer to our work and try to use it to guide themselves. So we don't have, because if we say we want to wait for a task force by the federal government, I think we'll wait. Okay, so this is just a list of all the task forces. As at that time, it will have changed by now. Then these are all the other steps. So you conceptualize the review, determine the research questions, and in determining the research questions, you consider what's most appropriate scope that you want to follow. Then all the issues concerning applicability, concerning that intervention. So it's not the setting, the location, the population, and so on. So because if you don't consider those things and you don't, right from the beginning, you might finish the process and then others can really, they really can't use it. They can't use your information. So, and then you now do the search for evidence. Like I explained, you put out that Boolean search, you define, then you come up with a huge number of papers, sometimes 25,000, sometimes 35,000, sometimes 40. So I've seen the 60-something thousand ones that just came out, papers. And you have just maybe initially the people who do the heavy lifting, maybe about 3 or 4 or 5 people to go through all that. So the first thing to do is to do the abstract and topic search. Yes. So, and then what you do is you do in pairs to make it faster. Again, management of resources. Some will say, for systematic reviews, there must be 3. Well, in CDC, then we were 2 people working independently, and then there was that coordination team that would also now weigh in to do consensus reconciliation afterwards. I'll get to it as well. So you get all that information, you read through, then you narrow down from that search. After narrowing down from that search, then you will now, those ones that make it to that initial weeding out of all those thousands, then you will focus and read through those ones. Those are the ones you now abstract information from. You synthesize all that information, put it together, and then you do quality of execution evaluations on them. So when you do that, then you're able to synthesize that information of the ones that are included. And then the ones that are not included are excluded from findings. Of course, finally, you present those findings. So let's go through the steps one by one. Coordination team, this was coordination team for one of the, that quick line I talked about. So this was the coordination team example. This was the topic, the effectiveness of telephone cessation treatment in increasing tobacco use cessation was the topic. So it's narrowed to that telephone use, that quick line. There was an agenda drawn up. There was an analytic framework that was designed for it so that we know exactly what we are looking for. Now, there's also something called logic framework. When you have the big broad topics, you will come up with a logic framework that talks about this is the big broad topic of violence or of road traffic accident and all, motor vehicle injury, they call it. Okay, what are now the various interventions that come out of that? So that's the logic framework. It's now from that logic framework, you now take one intervention and then you do an analytic framework from that one, which will lead you to your intended outcomes that you're looking at. So for this one, we're looking at increase in tobacco users successfully quitting. We're looking at reduced morbidity, mortality. We're looking at the disparities as well, and then a few other intermediate outcomes. So the research questions were, they wanted to know, does this thing, does it really increase quit rates among tobacco users? Does the effectiveness, does it vary by the type of the intervention, whether proactive or reactive? In this particular case now, proactive will mean that, the people doing the quit lines, they are the ones calling the person who wants to quit. The reactive one is that the person who wants to quit, the proactive one is the person who wants to quit is the one calling. The reactive one is that the call center is the one calling that person. And it makes a whole world of difference because now you know that the person who is doing the proactive one, actually the intention to quit is higher. So you will expect that, the outcomes will be much, the effectiveness of whatever counseling you're providing will be more. So they said, does effectiveness vary by characteristics of the intervention groups, of the intervention done, whether the content, whether the duration, whether the number of sessions done, they want to know that. Does effectiveness vary by the presence or absence of additional interventions, like the addition of nicotine gum or nicotine patch? So some of the studies actually did theirs, and then they introduced, that medication, giving it free. So, and so on and so forth. So at this stage, what you are doing is you are defining what your research questions are, basically. And then you look at all the possibilities on applicability. You have to define it right from the beginning. The system, because if you don't, you realize that at the end of the day, some other persons can't use it, or you've narrowed yourself too much, or you broadened it too much, and now you can't even draw conclusions from it easily. So the clients, the treatment providers, the types of services provided, so a lot of initial decision making that you have to, and brainstorming that you have to do in that team. Then you now go ahead and do your search for evidence. So for this particular review, since we conducted a broad search for all evidence, and you define the years. Those are the databases: Cochrane, Embase, PsycInfo, MedLife, PubMed. Then they look for existing systematic reviews. So because why waste all the time? In fact, in this particular case, there was a systematic review that was identified. They were looking for studies from 2000 to 2011. And then a systematic review done by Cochrane had already done virtually all the available studies up to 2009. So I mean, you are pretty much wasting time if you now go and restart all over again. So then We identified all the screen and screened each one of them, the studies in the executive reviews, and then we discussed it. And they had to decide whether to include it or not. So, and then we looked for other studies from that we found that met the criteria. So, this table, and it can be in any format. This is just one way of being able to present what you've been able to find after your search results. So 32,000 abstracts came out after the initial search. When the papers that had some potential benefit after that topic screen was 542, and then after further studies, we came down to the candidate ones, 2002, and then interventions for the update period was 55. So from 2009 to 2011, because like I said, the centenary review already had quite a number. So at the end of the day, many of those that were already captured in the review, the existing review, were now brought in, and then after the extra searches, the extra studies found that met the inclusion criteria was just 5 that was added. So if not, this process will have had, to include all 70 all over again. So they still included the information from those 65 studies that the existing review had done. So now the evaluation of the process, the evaluation process of each one of those studies, very, very detailed process. Very, it can be tough doing them. So now there is a lot of documents that they've developed that they use in evaluating the studies. It's actually a 28-page document that details out what you should do in each study, what areas to look at, what to consider, what not to consider. And then what you're actually trying to do is you expect the studies to do certain basic things. Now, if you now don't find those things, then you ding them. We call it dinging. We ding them with those limitations. Now you have up to 9 limitations to assign, and those with the higher limitations to exclude. So that's how but there are 6 categories, and the categories are the description. Did they describe the population and the intervention appropriately? Sampling, do they describe the sampling frame and the techniques they used? What is the eligibility, in being a part of the sample? What are the selection biases or not that are there? Did they even talk about it at all? So you look at these things. If they talk about it, then no dinging. It's 0. But if they don't provide it, then they get a limitation of 1. The next one is the measurements, the exposure measurement, the outcome measurement. How were they ascertained? Did they describe it thoroughly? What analysis was done? Did they explain how the analysis were properly done? If they didn't do that, then you ding them as well. Statistical outcomes and tests done and all that. Appropriate decisions from it, did they describe it? If they didn't, then you ding them. Then interpretation of the results. Did they talk about follow-up, confounding, biases, and so on and so forth? All the analysis done today. And then other things like quality issues, flaws, of the study, did they highlight it? If they didn't, then you ding them. So you have up to 9. And when you now have each study that you've evaluated that way, then you assign whether they are good, whether they are fair, or they are limited in the quality of execution. So if they have less than 1, either 1 or less, then they have good quality of execution. Definitely those ones are going to be included. If they have 2 to 4, then they have fair quality of execution, they will still be included. But if they have 5 and above out of 9, then you exclude them. It means that those studies, you really cannot rely on them. You have to now be worried about the internal validity and even to some extent the external validity of each one of those studies. So this just explains what I just said. The quality of execution is just one of those things that they look at. The other is the study designs. So there's another document they call the translation table that the task force uses to finally make their final decision. So quality of execution, very important. there's also the study designs. They try to, just like I began with, the various study designs, it helps to, they have different ratings for them. So the ones with the randomized control trials and all that have better study design ratings. So those ones, and they assign points. I'll show that table eventually. Okay, so now, of course, this review process, there are 2 people at a minimum. I mean, it really doesn't matter. You can do 3 for each study if you have enough human resources assigned. So, and then there's the abstraction form that you use, so it's standardized, so that we expect that what I will do, the other person will also do. Well, he's independent, I'm independent, we still need to come to a consensus at the end of the day. So that's the 28-page document. They published it, so it's readily available. Those are some of the considerations that they have to, that the abstractors have to think about. Was there no attempt made to address the concern? Was there an inadequate attempt? That's how they make the judgment to either assign that limitation or not. So it's all explained in that 28-page document, you know. So, and a lot of other information. What is an adequate description of the intervention? What is an adequate description of the population? So all of that is provided in that guide. So double abstraction is very valuable, like we said, independent opinion, and when you have consensus, you move on. When you don't have consensus, then you have to circle back, present that. I mean, the third party, in this case, is the team that is looking at it. What happened? Why is this not in agreement? And everybody will have to discuss, either convince each other or go back and redo it. So before you move forward. So that is the main process. And all of this has to be done before you can decide on what to do with each study. So potential problem in the conduct, abstractor judges it, assigns the quality of execution. I've already talked about this. The consensus check process, then the consensus resolution process, what I just explained. Then the decision you finally make, either to include or not to include. Then this diagram just shows what happens to each study. If first abstractor, second abstractor, if they agree, the study moves. It moves on to the completion stage, that, okay, we've completed the evaluation. If they do not agree, then, you know, you have to do that consensus and then finally take a decision. So when you are done, in fact, each person that is abstracting will have to produce something like this for each study. So this is called the detailed evidence table. You have to produce something like this for 8 minutes. Okay, I'll try to hurry up. It's very detailed. Unfortunately, I couldn't get a better, but it tells each category that you have to provide information on so that it's transparent. Because when you are doing that consensus, this is looked into by the third party. This is looked into by the third party, and they look at the other person's also. They want to know what your judgment is. Because some of them, you have 2 in each category or 3 in a category. So which one did you assign a limitation? Which subsection of it did you assign a limitation? I might assign it to a different subsection. I have to justify it. The other person might do it in a different, you have to justify it. So this is like what is the truth teller, basically. And then you make a summary evidence table like this of all of the ones that you now agree on. So each study you have to come up with this. Then you now begin to combine the findings and present to the task force. You look at where in this analytic framework the body of evidence points to in terms of your outcomes. So all of them, they were able to provide, because some of the studies provided more than one information. That's why you have 71. One of them provided 2. And then you provide some information about the various characteristics of the study, because it helps with applicability. What countries were they done? In what language? Because for the US it mattered. They only considered studies published in English. Some other countries might believe that, well, whatever is happening in China well, maybe the heavy population can affect us now. If we were to do it in Nigeria, we can decide, oh, if it's written in Chinese, we better find a translation app, translate it, and then be able to consider it, something like that. But they just didn't bother. They didn't consider, they considered mostly studies from developed countries. In few situations, in very few of their reviews, did they consider studies from developing countries. And they will have a justification for it because they are doing this for the purpose of their own country. So if we take a systematic review done by the community guide, we have to really consider this applicability issue. Does it really apply to us? And it's very important because now, even here now in Nigeria, we are doing something and the study population is mainly Lagos, Abuja, Port Harcourt. Is it applicable to the person in Sokoto, in Calabar, in other rural settings, and so on and so forth? So it's a very, very important aspect. So, and then all these other things are considered. So then they begin to present the evidence based on the various research questions. How many studies provided information on this research question 1, which is does it increase quit rates amongst those who are willing to do. So these are the number of studies, and so on and so forth. And then they provide analytic information as well from the studies, so that it's also part of what and if analytic information, quantitative information is not provided, the qualitative information provided is also presented. So the same thing, second research question, and so on and so forth. Then these are some of the qualitative information that they found. So, okay, this one says, does effectiveness vary by characteristics of the intervention, whether content, timing, duration? So all the studies that are related to that, information is also provided in that. Additional evidence that cannot be combined or put together or synthesized together is provided as individual information, and they justify why, and they state the reason why. Then also additional evidence, applicability issues, like I stated, are discussed as well. Additional benefits. This is very important because you might do an intervention and you have a purpose, something that you intend to achieve, the outcome that you looked at. But then by the time you now do all the searches, you find out there are other benefits that come with it. It's also important that in your systematic review, you are able to provide that information as well in your write-up, so that you inform the scientific community, and also potential harms. Same for the barriers to the client, barrier to implementing that intervention, either to the clients or to the beneficiaries. And barriers could be political, it could be cultural. I mean, you do something that is well received in Lagos, and then you get to some other part of the country, and they say, no, culturally, we cannot do that. You do something that is religious related, and people say, no, you can't do that. You want to do an intervention that involves you touching the opposite sex, and then you go to where that is not allowed, then you know that you are in for trouble, because you're actually copying and you are not pasting properly, So, and then they do an economic evaluation. Of course, they present their summary of findings to that task force and provide all the information, whether the findings, if the effect size they got, if it's meaningful or not, whether there's sufficient or insufficient evidence, and whether it's strong, sufficient, or insufficient. That's how they rate it. If it's strong, it means that they have enough studies that are quality, the quality of institution is higher, and so on and so forth. If it's sufficient, I'll show that translation table now. And then if it's insufficient, it doesn't actually mean that your effort is useless. It just means that more studies are needed. It doesn't even mean that that intervention is not useful. It just means that there's not enough evidence to show that the thing works or not. So, and they look at all the other things, morbidity, mortality. And then the evidence gaps. What are the things that were not addressed in all the studies that you looked through, that you were able to find? So what were the evidence gaps? It must also be highlighted in your systematic review, so that helps the next researcher to know the areas to look into and be able to provide the evidence on them. So this is the translation table that I was talking about. So in terms of quality of execution, we have good or fair, weak. I explained that before. In terms of suitability of the study design, you have greatest or moderate, and then you have whether they are consistent or not, and then the number of studies in each category. It helps with taking that overall decision. So they have strong, they have sufficient, and then they have insufficient evidence. So this is what the task force finally, based on the information provided to them, they now go to this translation table where does all the information, the studies you found and the results found, where does it fall on this translation table? And then they use that to take their final decision to make a recommendation of whether there's strong evidence that supports that this intervention works, or there is just sufficient evidence that supports that this intervention works, or there's insufficient evidence that this intervention works. So either of those three, and that's the final take. So, okay, these are some of those statements that they make. So I just explained that. This is just a comparison of both the USPSTF and the CPSTF. The areas covered by the USPSTF, we can see it's narrower, it's smaller relative to that of the community, which is the broad-based one, which is where most of us function in terms of public health, really. And then there are overlapping areas in between the two. So this is their website. We can go there and get more information. We can go to Cochrane, NICE, all the other ones, and get more information about their methods to learn more about systematic review. So my last slide, I said, can we have a hub? It's a question and a challenge to all of us. Can we put people together and have a hub for systematic reviews in any one of our academic institutions in Lagos? I want to thank you for listening. Thank you.
Thank you very much for that. So we have the question and answer session. Do we have questions, comments? Questions? Questions? Comments? Okay, let me take, before I ask my question. Yes, sir. When are we going to have that last slide? You are a policymaker, sir. So when are we going to have it? Okay, Dr. Olufunlayo, let me.
Thank you very much, Honorable PS, Dr. Piton, for this, your insight on systematic reviews. I think the call is critical. And like I said in the morning, this conference should be an opportunity for us to have a call to action. I think Dr. Noiga also mentioned that. So the hub is an excellent idea. We've been doing little things in our space, but we haven't been able to make that impact. So I think all those with expertise, we can put a group together. I don't see why an institution like Calabar would have cornered Cochrane, and they've gone far. So there's so much we can do. So thank you very much for the presentation and for this opportunity. We look forward to that.
Thank you very much, Dr. Piton. My question has to do with some of the tools that are used for systematic reviews. I don't know if you could share, some that you've used. I know there's some for screening, some you use, like even for the flow charts, they're actually specific tools for new updated systematic reviews, Prisma, and if you could share some information about the tools, helpful tools, even for grading quality and all that.
I'll go back to. I have some saved on my computer. I'll check. And
No,
then
it's
I'll,
okay if you.
and then
yeah.
I'll go back to the.
I just
to
thought
the,
it might be good for people
Yes.
to know.
I think it's very important, man. So that at least we know that we're the best thing we can do is to copy first and foremost, and then see how we now paste in accordance with our own use. So I get what you're saying, ma'am.
Thank you very much, sir. So you have heard Dr. Lufulayo said something. We have the Permanent Secretary, Health Service Commission here. We have the Permanent Secretary of Health District 4. We have the Permanent Secretary of Health District 1. We have Professor Onojole from Luth. We have Professor Mobolanle Balogun from Luth as well. We have Professor Okafor from Luth as well. We have Professor Wright from Lassuth. So we have a hub already.
So let me add this. Because of the tedious nature of conducting systematic reviews, it's very, very time consuming. Very, very time consuming. I mean, the people at the community guide, the people at ARC, the people at Cochrane who are doing the heavy lifting, that's their job. That's their job. So when I was doing fellowship there, they were paying us something. So you understand? So we have to have, for it to work, there has to be some fund provided. Who will provide the fund? You and I will have to, the answer to that more than me. Okay, but the point is that some funds has to be provided so that there is some stimulus for the hub to function.
Just to say that we're not starting from ground zero. As she said, I mean, there are groups in Luth. I think there's a Dr. Oku, is it Okusonga or something in ONG, that's his forte actually. He's part of this Cochrane group. He's actually also trained some of the academic staff in LASUCOM as well. So we're not starting from ground zero. We just probably need to up our game a little bit more. So this is really, really very insightful. I think we've taken this to a whole new level with registration of some of these protocols on OSF, getting conversant with the use of things like Covidence and all of that. But like you said, it's a very, very technical process. And well, God will help us.
Thank you, ma'am.
Thank you very much, sir. And Professor Wright, you are the Secretary of the High-Level Research Strategic in Lagos State. So I think you can push this to, you understand.
Actually, you know why I'm throwing it back at you? See, thank you very much, man. That's why I'm throwing it back at you. Because the funds to support it can be domiciled in your unit. A round of applause, please. Yes, it can be domiciled.
With the help of Professor Olalade, right? So we can push it together. Yes, thank you very much. We are actually going to include it into our annual operational plan. And I know that with the help of Professor Olalade, right? So when we are having that meeting, so that you'll be able to, so that at least, just like what Dr. Lufulayo said and what Dr. Onoiga said, that something must come out of this meeting. So thank you very much, sir. So on this note, please, can we give our Permanent Secretary a round of applause? So while I invite Dr. Hello to take over.
Thank you all so much for your patience so far and your attention. At this point, we'll move over to our poster presentations. So we'll be exiting the hall to the lobby out here to observe the posters led by the chairperson of the scientific committee, Professor Akinka, as well as the judges. So all the poster presenters, please go stand beside your posters. Our judges, please, you'll be there to assess the posters as well as the chairperson. So we're going to be viewing posters. Go identify the posters that resonate with you or that you would like to listen to. Thank you. Professor Kinga, please.
Yes, ma. So, good afternoon again. So it's going to be based, the poster sessions will also happen simultaneously and will be based on the teams. So team A judges are going to assess the posters that we see on my right here as we come in. So that set of posters. And then team B judges will assess the ones at the back here on the other side. Please note our darling judges that the posters have been pasted according to time of arrival. So they are not following the normal schedule that has been put in your assessments. So please, when you do get to the posters, please just record the number, the abstract number for that poster before you start assessing. Just cross out the old one and record the abstract numbers. And each presenter there has just 5 minutes. So our timekeepers, thank you very much. So timekeepers will please go along with the judges, and then everybody else can also go along. Please, let's be there, but maybe not crowd too much, so we can also look at the posters, and then later on, you can take more time to take closer looks at each of those posters. Thank you very much. You know.
Isikhathi sokuphefumula sikhala lapho umsindo uyaphela, lapho umoya kuphela uyashintsha, izandla zomoya zidlula phezu kobuso bomhlaba, sihlanza izinsalela zesikhathi. Lapho siphefumula la izwi elishalila, ngaphandle kokukhuluma umhlaba uyaphendula. Izintaba ziyahlisa izwi lawo zokubuka amathambo athule, amanzi ayema phakathi kwedwala, izulu liwele emhlabeni ngendlela yokuthula, futhi inhliziyo yathula nayo. Kukhona umkhulu ongabonakali phakathi kokuphefumula, owenza umzimba ukhumbule ukuthula kwawo kwangaphakathi. Isikhathi asidingi kukhanya noma ithunzi, sidinga ukuphefumula ukuze sikhumule ukuthi siphila. Ukuphefumula kusikho kuzala ukudlala phakathi kwendawo yokuthula engena umkhawulo. Isikhathi sokuphefumula siyisikhathi sokuphila, lapho umzimba uthule umhlaba uyaphila mkhaya. Isikhathi sokuphefumula siyisikhathi sokuphila, lapho umzimba uthule umhlaba uyaphila mkhaya. Amagama yaphela kodwa umoya uyaqhubeka, njengomfula ongabonakala phansi kwesihlabathi. Lapho isithunzi sidlula ukukhanya kuvela, lapho siphefumula siyakhula ngokuthula izikhathi eziningi zidlula ngaphandle kokuzwa kodwa kuphefumula kuqhina zonke izindaba ezilula ekuthwineni lapho konke sekuthule umoya ushiya umzimba kodwa uhlale emhlabeni isikhathi azipheli siphefumula phansi kwezinyawo futhi thina siyathula sibe nomoya wonke womhlaba isikhathi sokuphefumula siyisikhathi sokuphila lapho umzimba uthule umhlaba uyaphenakaya isikhathi sokuphefumula siyisikhathi sokuphila lapho umzimba uthule umhlaba uyaphenakaya izindaba zigijimi zime ngendlela yobubele ithunzi lazo lintlusa umzimba kubathule lapho umkhele welanga udlula etheleni amandla ayahlala esokweni sokusola kukhona izintambo ezingabonakali eziphakamisa inhliziyo ngaphandle kwensindezi amanzi angaphansi ethwala yahamba kodwa ngakhulumi akha izindlela ezinkane avusa umusa amandla usiza ukulwa awumemezela ububele awonakalisi aqima ukuma amandla athule isikhamu sesithunzi ayigugu elihlala esikhaleni sokuphefumula uthuli olukhanyayo luyaphakama luhlale emoyeni ludwebe imigqa yokuthula emqondweni lapho izinyawo zinganyakazi phansi ukuma kwenhliziyo kuyaphila kabusha amandla mawema ephotekayo awona ukhona aphansi ajulile ezindawo lapho ebusuku izinkanyezi zisondele phansi amandla athule beyisikhwama sokufudumala asondeza umphefumulo emzimbeni futhi umzimba uyaphendula ngokuthula. Izwi lenkumbulo liyaphenduka njengomoya ophuma emadwaleni, liphatha izikhathi ezingapheli, likhuluma ngezwi elingabonakali. Izwi lenkumbulo lihlala emoyeni, lingakhohlwa kodwa alinyamalali. Izihlahla ezindala ziyalizwa, zidonsa amandla asophansi, izilwane zithula lapho liphuma njengomoya wokuhlonipha isikhathi. Izwi liyahamba phakathi kwezintaba, liyaphenduka phakathi kwemimoya, ngaphakathi kwalo kukhona ukuthula okuhlala njalo ngaphandle kwesikhathi. Izinyengulo lihlala emoyeni, lingakhohlwa kodwa alinyamalali. Izwi lengulo lihlala emoyeni, lingakhohlwa kodwa alinyamalali. Izinyembezi zomoya ziyahamba, zigcwalisa isibhakabhaka ngokukhanya. Izwi lengulo lihlala likhona njengomthunzi wokukhanya okudala. Izwi lengulo lihlala emoyeni, lingakhohlwa kodwa alinyamalali. Ilanga lasekuseni alikhanyisi ngamazwi, likaqamba phakathi kwefuyo elincane. Amanzi emabele imvula yawa ngothando. ithinta umhlaba ngemilomo yamanzi. Isikhumba somhlaba siphefumula ngokuthula, kanti isikhathi simasibuka. Imvula yokuthula yahlanza umoya, ithoba izwi lezwe libe imfudumalo. Izimpande zihleka emanzini azayo, izihlahla ziyazamazama ngokujabula ithule. Izilwane zilalela izibuphu zemvula, njengomthulo wokuphumula. Ule mvula komoya wothando, ongeza ukuthula emzimbeni wonke. Izulu liyakhalela ngezwe liphansi lothando. Amadwala athwala amanzi ngokuthula, izintaba ziyaphendula ngeziphepho ezithambile. Imvula iyaphenduka ibe umthula omncane, oqhubeka ngemva kokuma kwayo. Ngaphakathi kwehlathi imfula yathula, ngaphandle komuntu isihlabathi siphuza. Lapho izulu lithula ngemva kwemvula, amazwi ezinhliziyo ayaphuma. Imvula yokuthula iyeka amanzi, kodwa ishiya umoya othambile phakathi kwethu.
Presentations. Let's round up the oral presentation.
Welcome back, everyone. Please be seated. Can we take our seats, please? Can we all be seated, please? The session is about to start. Can we be seated, please? We're about to go into the next session, and we're going to have a presentation by none other than the chairman of this conference, the person of Professor Aki Oshibogun. But before he will come up, I'd like to call on the chairperson of this session to give us an overview of the session prior to Prof's presentation, in the person of Dr. Atinuke Onoiga. Please come up. A round of applause, please, to encourage her as she comes up.
So where is it? Okay, I'll call you. Don't worry. To do it. So, again, distinguished colleagues, are we all ready? Hello? Are we ready now? So, distinguished colleagues, esteemed fellows, ladies and gentlemen, I'm honored to welcome you to this sub-theme session, and it's focused on the postgraduate fellows program and the gains of the health sector, with special emphasis on redefining the role of the public health physician in contemporary Nigeria. As we all know, our health system is at crossroads. Nigeria faces a growing burden of preventable diseases, persistent health inequities, limited access to quality care, and a dwindling workforce within a system struggling to keep pace with global public health demands and challenges. At the center of these challenges, positioned to provide solutions, because we are all solution providers. That's what God made us for. Are public health physicians whose training prepares them not only as clinicians, but also as system thinkers, data analysts, health strategists, policy advocates, leaders of disease prevention, and custodians of community well-being. Are you not going to give a round of applause for who you are? Because you have to know who you are before you can be able to act as you are supposed to be. That's your DNA now. Yet, despite this specialized training, one of the realities confronting us today is the absence of a clearly defined career pathway and employment framework for newly qualified fellows of public health, especially outside the tertiary academic environment. Many brilliant, highly trained specialists complete the rigorous fellowship of National Postgraduate Medical College of Nigeria, only to face uncertainty regarding their placement, appropriate utilization, and career progression within the broader health sector, particularly in state health systems, general hospitals, public health agencies, and sometimes even in the primary health level. The sub-theme aims to provide a platform to examine this problem openly, review the gains that the fellowship program already brings to the sector, and engage stakeholders who are positioned to craft practical and sustainable solutions. Today, we are privileged and indeed honored to have with us Professor Akin Oshibogun, one of the most, please give him a round of applause if you want to, one of the most respected voices in public health in Nigeria, a former president of the National Postgraduate College of Nigeria, former chief medical director of Lagos University Teaching Hospital, and an active leader in multiple national committees. Professor Oshibogun has shaped policies, mentored generations of physicians, and championed reforms that continue to strengthen our health system. Thank you. He is uniquely positioned to contextualize the fellowship program, outline its values, and cast a vision for how public health physicians must evolve in the face of the modern challenges before us. I will now call on someone to read a short citation of Professor Oshibogun, and I said an abridged short citation as he proceeds to give us that brief address on the keynote address on this topic. So following this address, we'll proceed to a robust panel discussion, and we'll have a composition and bevy of people who will actually add value to that. So I'll call on the one who is making the citation to invite Professor Oshibogun in. Thank you very much. I humbly invite you to stand up for the citation. Yes.
I get the rare privilege to actually ask my teacher to be upstanding. Well, I do that with every ounce of respect, sir. Okay. So our speaker today is Professor Akin Oshibogun. Professor Akin Oshibogun is a graduate of the University of Lagos with an MBBS, has an MPH from the University of Columbia, MD from the National Postgraduate Medical College of Nigeria. He's a fellow of the National Postgraduate Medical College of Nigeria in Public Health and Community Medicine by examination, a fellow of the West African College of Physicians by examination, a fellow of the Royal Society for Public Health, elected on merit, Foundation Fellow, Academy of Medicine Specialties of Nigeria, elected on merit, and a certified public-private specialist. He was a visiting fellow in the Liverpool Epidemiology Program at the Liverpool School of Tropical Medicine in the UK in 1994, international fellow at the Andrija Stampa School of Public Health, Zagreb, Croatia in 1993, and a participant at the Strengthening Human Resources for Health course at Harvard School of Public Health, Boston. He is a member of several professional bodies, including the Association of Public Health Physicians of Nigeria, the American Public Health Association, the Nigerian Medical Association, the New York Academy of Science, and the International Society for Infectious Diseases. He served as short-term consultant on health system strengthening to WHO Geneva on various dates between 1993 and 2003. From October 2006 till October 2014, he served as the Chief Medical Director, CEO of Lagos University Teaching Hospital, an 800-bedded university teaching hospital, and currently serves as the Vice President of the National Postgraduate Medical College of Nigeria from January 2020. He has personally supervised well over 100 postgraduate theses at master, PhD, and fellowship levels, and is well published in both local and international journals. Join me with a resounding applause as we welcome Professor Aki Oshibogu. Thank you.
Thank you very much. Thank you very much. Madam Chairperson, my esteemed colleagues, it's indeed a pleasure for me to be here with you. I never take associating with my colleagues for granted, and I will go to any length to be with you. I must apologize for coming so late. It has been, of course, I also learned after getting here that the news has preceded me to get, in getting here. But the Nigerian Medical Association, the association to which we all belong, decided to confer on me its highest award, its highest honor. The fellowship of the Nigerian Medical Association. I dedicate this fellowship to you all. From my understanding, this fellowship has been awarded only to past presidents of the NMA. I've never been assistant secretary in NMA. I've never even been assistant PRO. So how it became my turn, only God knows. But when it was conveyed to me that I was going to be awarded, I gladly accepted the honor. Because as professionals, particularly as medical professionals, we don't honor ourselves sufficiently enough. And when you look at national honors, of course, at times you feel that even if they offer you, you will decline. Because the people they offer are traders. They don't consider, to get Stella Dadevil recognized, it took us 5 to 10 years. I think the Ebola outbreak was 2014. And several of us here participated in trying to control that outbreak. Of course, she was the one who arrested the first patient, the Index case. Fortunately or unfortunately, at that level, Jide Idris and myself were classmates at Idi Araba. So when she had that challenge, and I was CMD at Lutz, she called me and said, this was what she had. And I said, don't let that patient go anywhere. And then, of course, got Jide Idris, and Jide Idris got back into the country overnight. The rest is history. And then it took us so long to persuade the government to at least recognize one person. If it was a football team, you will have given all of them houses. And so the Aphpn must also start recognizing. Of course, I have had 2 or 3 hours from the Aphpn, but we need to laud it. We need to laud it. So pardon me for digressing, but it's because I'm excited. I'm excited to be here with you. Public health is my passion, and the medical profession has granted me the room to be myself. If I come back the next time, I'll still be a doctor. And as some of you may know, two of my daughters also, they thought that that was the place to be, medicine and they are not only doctors, they are also in public health. So you can see why I don't joke with Aphpn matters. But today, because of brevity, I need to be a little bit direct, and because of time, I don't know what disruptions I've caused. Again, I plead that you kindly forgive me, if only for this medal that you are looking at. So let me show you again the reason why I came late. So my whole talk this afternoon is for us to rediscover ourselves. Because if you don't know who you are, people will take you for anything. So let us rediscover ourselves. Let us understand what we are doing. And once we have that confidence, we can tell them to keep quiet. Because our profession is a profession that is highly at risk, because a lot of people are envious of your being a medical doctor to start with. Then if you're a specialist, the envy is multiplied. So you need to rediscover yourself and be sure of what you are, and then you can tell them to keep quiet. The first thing is, if you look at JAMB admissions, and you look at the requirements for admissions into medical school, and the post-UTME requirements, I don't think anybody is in doubt that you need to have all the A's, and have, at least at the University of Lagos, you must score well over 280 to even be able to get your leg in the door. For other courses, if you have 220, 210, you go in. And these people then turn around and say, what is the medical degree all about? So my talk this afternoon will try to help us to rediscover ourselves and then to tell them to keep quiet. The first Nigerian, incidentally, I'm coming from Abeokuta, and Abeokuta was where our first attempt to train doctors started. I think we should also note that. Because the Sacred Heart Hospital was the first true hospital in Nigeria in 1859. It was started by Reverend Father Cockwood. And then after that, they tried to start training doctors. Obviously, it was not a successful experiment. They moved to Yaba in Lagos. They started training doctors, and their products also only became assistant medical officers. Of course, some of them then proceeded to the UK and got additional training. So now you are looking at people like late Professor Omaru Shehu, late Professor Likwe Ransom Kuti, and there was a Major General from Kanu. I've forgotten his name, because there was also a small experiment in Kanu to start a medical school. All that also fizzled out. But the medical school at Yaba eventually there was an attempt to move it to Abeokuta, but the Egbas refused to provide the land. I don't know whether it was a mistake. But the school then went to Ibadan, and Ibadan got the medical school affiliated to the University of London. My very good friend, who was not fortunate to come to the University of Lagos, graduated from Ibadan. I'm talking about Dr. Tunde Lawal. We've been together for quite some time. So the first Nigerian doctors, Aphpn and Davis, qualified from King's College. I will not spend so much time on the PowerPoint, seeing that we are starting late, so I'll just try to quickly speak to my presentation. From King's College in 1858, but by 1940, there were less than 50 Nigerian doctors. The number grew to 170 by 1950, and only 270 by 1960. By 1970, the number increased to 1,400 and over 8,000 by 1980. Today, there are about 85,000 Nigerian doctors scattered all over the world. About 45,000 have renewed their licenses with the Medical and Dental Council. So you can see that more than half of the Nigerian doctors are not here. But what I want to draw your attention to is that exponential growth in the number of Nigerian doctors. And that exponential growth can be linked to the activities of the postgraduate medical colleges. Because once you started producing the teachers, then the teachers can then produce more and more doctors. So over 80% of the clinical teachers in Nigerian medical schools are the products of the postgraduate medical colleges, either Nigerian or West Africa. The products of this training, that's the products of the colleges, of the postgraduate colleges, can be found everywhere around the world. One Nigerian doctor in the United States operated on a pregnant woman, brought out the baby, operated on the baby, they returned the baby, and that baby was born twice. That doctor, that Nigerian doctor, was trained at Ife, not even in Lagos. Ife, that's, yeah. Yes, yes. I needed to be sure that you are awake. Because I suspect you will have had lunch. So if I prick you, then you will wake up. He was trained at Ife. So the products of the training thus provided can be found doing excellently well in medical practice in different parts of the world. It is estimated that about 15 to 20,000 Nigerian doctors are practicing in the United Kingdom and USA alone. If the products of Nigerian medical schools trained by the fellows of our postgraduate medical colleges are doing so well, what is informing the logic of attempts to downgrade these medical fellowships? So that is your first argument. Your products are doing so well all over the world, so why should anybody tell you that you are not sufficiently qualified to train? So the first function of the products of this program is to train, is to teach others. I hope that this paper will firstly afford us the opportunity of introspection and possible improvement, and secondly, to make information available in the public space, especially for those in faculties outside medicine who have failed or refused to understand the traditions and methodologies of medical education. Those who have attempted to ridicule the fellowship training programs and the certification that follow are indeed entitled to their opinions, but are requested to, in the true traditions of intellectuals, be open enough to interrogate alternative opinions. They must be humble enough to bow to superior arguments. And the very first point that needs to be understood is that the fellowship of the postgraduate medical colleges are not honorific. The fellowships of the postgraduate medical colleges are not honorific, but rather they are awarded following sources at the completion of a detailed training curriculum and passing at required examinations at different levels. So it's not the same as fellowship of the Nigerian Institute of Management, which they give you if you've been a manager somewhere for some 10 years or so. This one follows the completion of a detailed curriculum and followed sources at specified examinations. The second point to note is that while the university is a very important institution for the dissemination of knowledge, it does not have a monopoly of knowledge. As will be seen later, medical education can only be provided in practical environments. If human lives are to be protected adequately by the products of training programs, it will indeed be disingenuous to discountenance the functions of university teaching hospitals in the acquisition and dissemination of medical knowledge. And these and similar centers are where undergraduate and postgraduate medical education largely takes place. In Nigeria, the National Postgraduate Medical College has been empowered by law to oversee postgraduate medical education and to award degrees, diplomas, certificates, and any qualifications that, in that respect, as it may deem fit. In Nigeria, and similar to traditions in the United Kingdom, United States of America, Canada, etc., the college awards its fellowship as the highest postgraduate qualification. This fellowship is a postdoctoral qualification, as we will see shortly. It is higher than any doctoral degree, but they don't understand. And you need to understand so that you can educate them. If we go into the didactics of what education is all about, of course, education as a word is derived from the Latin word educere, which means to lead out. Education must therefore be the means of leading people out of darkness into light. It must be a means of passing known facts and skills from one generation to the next, validating what is already known and inquiring into what is not yet known, and finding answers. With little variation in approach, depending on discipline, it is obvious that the earliest type of formal education was largely apprenticeship, where students learned at the feet of masters. The process was structured such that the students started from simple things like carrying the master's bag and maintaining the cleanliness of the general environment. As the student progressed, by observing the master, he was gradually allowed to handle the tools and did minor aspects of the work. With further progress, the student was allowed to do more important aspects of the work under the master's supervision until the master was convinced that the student had gained sufficient proficiency and could do the job on his own. After some more demonstration of competence, the student was pronounced free to practice the trade. That is what is dominant in medical education. The early universities in Bologna, 1088, Paris, 1119, Oxford, 1167, and Cambridge, 1209, adopted the participative approach to learning and inquiry. They were built on internal government and institutional autonomy. This autonomy is important to engender freedom of thought from which innovations can emerge. Universities have adopted the two main objects of education alluded to at the beginning of this section, which are the dissemination of knowledge and the expansion of the frontiers of knowledge. This must be a very difficult combination as we learn from the idea of a university. There's a book with that title, Idea of a University. And from that book, we learn that the greatest thinkers have been too intense on their subject to admit of interruption. They have been men of absent minds and idiosyncratic habits and have more or less shunned the lecture room and public school. So those who are intellectuals at times can't even give lectures because they are too busy thinking and conceptualizing, that they can't afford the time to stay in any lecture room. So Pythagoras was said to have lived for a time in a cave, while Thales lived in private and refused the invitation of princes. Plato withdrew from Athens to the groves of Academus, while Aristotle gave 20 years to studious discipleship under him, and Isaac Newton indulged in an intense severity of meditation, which almost shook his reason. He almost went mad. And I'm sure we all remember Newton and his principles and so on. And I won't go into Albert Einstein, whose PhD consisted of only 28 pages. 3 were texts, and the remaining 25 were equations that his professors did not understand. No other school, faculty, or college in our universities has been better able to combine the two main functions of the university than their colleges of medicine. The staff of these colleges not only teach and research, They also perform well the third function of the university to render service to the community. The construction of medical education structure and process has been responsible for these often unacknowledged sources. It will be counterintuitive to compel medical educators whose current training has enabled them to function well in research to now go for research-based PhDs. So somebody has already published 50 papers in decent peer-reviewed journals, and you're asking the person to go back and get a PhD, which largely is to train to be able to conduct research. It doesn't make sense to me. And we've tolerated that nonsense for long enough. Pardon my language. Regulation for basic medical education comes from two government agencies, the Medical and Dental Council of Nigeria, empowered by the Medical and Dental Practitioners Act, and that body has no problem with the curriculum of undergraduate medical education, and also does not have any problem because it's also on the council, the governing board of the National Postgraduate Medical College, so it's quite aware of what the curriculum is about. The Medical and Dental Council of Nigeria has provided a red book detailing the minimum standards required, but then the NUC also comes up with its own minimum requirements. So I guess this has to be something that has to be continuously debated. Who truly should design the curriculum for medical education? So the National Universities Commission has produced the minimum academic standards, which it upgraded first to the benchmark minimum academic standards, BMAS, and now to the core curriculum minimum academic standards, CCMAS. The CCMAS from NUC accounts for 70% of the curriculum, and each university senate has the liberty to add the remaining 30%. I think this is still work in progress. Many universities don't understand what the NUC is saying or how to add the 30% to the curriculum. While the NUC regulates the universities, all graduates of medical and dental schools from Nigeria and other parts of the world can only practice medicine or dentistry in Nigeria if the MDCN is satisfied by their training and registers or admits them into practice. It is gratifying to note that both the NUC and MDCN have been collaborating recently, and particularly in the area of joint visits for accreditation of medical and dental schools. We recollect that basic medical and dental education is currently generally structured into basic sciences 1 year, basic medical sciences 2 years, basic clinical sciences another 1 year, and clinical sciences 2 years. But of course, my head of department is here. He knows that community health is not taught in the final 2 years. Community health is taught all across, so it's intercalated throughout the entire program. The CCMAS from the NUC has outlined credit units for the various courses in the medical and dental curriculum to facilitate the issuance of transcripts for students who need it and who need it for any legitimate purpose, even though the degree MBBS, BDS will remain unclassified. The calculated total credit units for MBBS and BDS in the CCMAS are 474 credit units for MBBS and 413 credit units for the BDS. I should draw attention to the fact that for the ordinary bachelor degrees in all the other programs, the total credit units, the highest you will get is 250 credit units. So for medicine, the credit unit is 474. So why do they want to earn the same salaries with somebody who did 474 credit units and you've done only 200 credit units? I think that in one of the states, there has been that argument recently, and they've been slashing people's salaries. I did not mention any states. At least you didn't hear anything. And I'm not yet done. The attributes required of a doctor to be able to bear the enormous responsibilities of his office require training in areas not captured in the curriculum or training in areas in the hidden curriculum. So apart from the open curriculum, so there's also what we call the hidden curriculum. These attributes include the ability to recognize your own limitation. It's not in the curriculum, but as a medical doctor, you must recognize your limitation. You must practice with integrity, and you must have the habits of truth. And of course, you must be equanimous. You must be able to face the realities of life in the face. You are on call, a patient died, in another 30 minutes, another patient dies. You must be able to face all that without going berserk, without losing your senses or your composure. So, and then of course, you must also remain humane. In the middle of it all, you must show compassion. Other attributes such as the ability to work hard can be acquired through the rigorous nature of the training. So I was discussing with some resident doctors and there were complaints. In fact, now there's something trending. You see in some centers, a doctor is on call for 26 days out of 30 days. So that's the ability to work hard. So my advice or although that's also because of the Japa syndrome, so many centers are short-staffed. So my suggestions to the resident doctors was that they should insist on maximum number of working hours. We are not the first to go through that journey. It happened in the UK when doctors started falling down on call. A house officer fell down and died. Then people had to sit down and say, no, you can't be doing 80 hours call per week. You can't be doing 100 hours a week, and then you can negotiate that, okay, if other civil servants do 40 hours a week, let us at least say 60 hours a week. And then let government incentivize people to come back so that you'll have more. And then, of course, we need also to train more. The proper training of doctors cannot be achieved purely through didactic methodologies, must be through appropriate apprenticeships in small groups or firms. This will allow for adequate medical socialization and the imbibing of professional norms and etiquette. So medicine can only be taught through some kind of mentorship. It cannot be taught like history, and you cannot do it online. Medical education is not cheap because of these very rigorous methodologies for teaching and learning. Medical education is not cheap anywhere in the world. And the production of good doctors can only be intentional and not rushed. To appreciate the work of our postgraduate medical colleges and their products, the trainers that they have produced, we need to look at what it costs to train doctors in the United States, for example. It costs on average about $250,000 as tuition for the 4-year medical school, and another average of $120,000 in tuition for the 4-year pre-medical school. So to produce a doctor in the United States, it costs just $370,000. So you can understand why they are looking for your doctors, because even they cannot rush the production of doctors. They have gaps and they cannot rush the production. So they are eagerly snatching doctors that have been trained in Nigeria and other countries. And because we've trained them so well, the quality is high, so it's acceptable to them. Most states in the United States now require 1 to 3 years of residency training before licensure. So in addition and on top of that 370,000 naira, they must also undergo some residency training. And it costs the United States government $1 million to train each resident doctor. $1 million. So you can see again why they are snatching us and why we are not pushing the right arguments to the policymakers so that they understand the work of the postgraduate medical colleges in producing the trainer. I think these calculations give us an idea of why doctors from Nigeria are in demand in developed countries who have physician shortages and are in need of well-trained doctors from Nigeria. As I mentioned earlier, 80% of the trainers of these doctors were themselves products of our postgraduate medical colleges. If it is working, why change it? If it is working, why fix it? Whilst the National Postgraduate Medical College of Nigeria is saddled by law with responsibility for postgraduate medical education in Nigeria via Decree number 67 of 24th September 1979, now Cap N59, Laws of the Federation of Nigeria 2004. It also collaborates with the Medical and Dental Council of Nigeria, which agency has responsibilities for registering all doctors and dentists in Nigeria, including specialists. The core postgraduate medical training is based in teaching hospitals accredited by the postgraduate medical colleges for residency training. By law, the National Postgraduate Medical College of Nigeria has responsibilities for agreeing on postgraduate medical education curriculum in Nigeria and is mandated to publish such curriculum on its website. Decree 59 of 1979, NPMCN Act, and the Medical Residency Training Act of 2017. Apart from neurosurgery and 1 to 2 other programs lasting a minimum of 8 years, the average residency training program consists of a 3-year junior residency leading to the Part 1 examination of the college and a 3-year senior residency leading finally to the Part 2 or final examination of the college. Successful candidates at this final examination are then awarded the fellowship qualification of the college. For each specialty of medicine and dentistry, there are defined courses of study which are achieved through didactic lectures, seminars, tutorials, daily ward rounds, consultation clinics, medical surgical procedure sessions, monthly multi-departmental grand rounds, MOH postings, rural postings, environmental postings, occupational health postings. Tell me which other PhD program goes through all this stress. Sorry, I'm so passionate about this, but the medical residency program is so intense that if the credit unit system were to be applied to it, it will not be less than 300 credit units. And you can quote me anywhere that I said that it will not be less than 300 credit units. A regular PhD program requires only about 50 credit units. So it's more than twice, thrice, 4 times, 6 times. A further requirement for resident doctors to complete the training program and qualify as fellows of the college is that they must demonstrate the ability to gather data and obtain evidence that can add to what is known or validate what is already known, or provide evidence through research that can solve health problems. So our forefathers, the people who designed the program of the National Postgraduate, they had foresight. So what they designed had already incorporated academic training, professional training, and leadership training. Even the UK residency training program only started copying our program recently. They were not doing research. So they only started now incorporating research into their fellowship requirements. So other countries are now beginning to copy what we are doing. If we then remind ourselves of what the PhD or any other doctoral degree is intended to demonstrate in terms of ability, we will see that the fellowship certification of the college demonstrates far more and varied ability in the holder. We must also bear in mind that PhD is not the only doctoral degree. There are other doctoral degrees such as Doctor of Education, Doctor of Divinity, Doctor of Science, Doctor of Medicine, and in the UK, the Doctor of Medicine is a postgraduate doctoral degree program. And these are even referred to as higher doctoral degrees. So they are even higher than a PhD. So when you have a DSc, an MD in UK, it's a higher doctoral degree than a PhD. Residents of the National Postgraduate Medical College of Nigeria alone produce some 300 to 400 research dissertations annually But unfortunately, because they do not understand what we are doing, these residents are denied access to TED fund, because the law establishing TED fund mentioned the word university. And as I said, universities do not maintain a monopoly of knowledge. The National Postgraduate Medical College, even though it's not named a university, they've been trying to bring us under NUC. They said, you people, so that if you want TED fund money, let's rename your institution. Well, I said it won't be under my watch. So it didn't happen while I was president of the National Postgraduate Medical College. My colleague said I was vice president of the National Postgraduate Medical College. Yes, I was vice president, then became president, and then left office as president. So I'm a past president. But thank you very much for your words. So universities don't maintain a monopoly of knowledge, because knowledge can also be elsewhere. And we prefer that our postgraduate medical college not be lumped with other 70 or about 200 and something universities now in the country. Because once they lump you with them, then they will tell you how you should teach. And you cannot teach medicine as you are teaching history. Some of the capabilities for which fellows of the college have been trained during the residency training program. I've been trying to speak in parables, mentioning the capabilities and mentioning the training requirements, and mention to also indirectly mirror the functions and the roles that we are expected to play. So only the wise and those who have eyes of faith will get through the message. Some of the capabilities for which fellows of the college have been trained during the residency program and for which they have continued to demonstrate competence are patient care, teaching, research, ability to raise funds for research and community projects, academic writing, public speaking, logistics expert, mentoring, graduate application assessment, and administration. It is agreed that research offers the opportunity to add to knowledge and also enhance the transmission of knowledge. And this is the main argument for insisting that university lecturers must have a PhD. If that is so, then fellows of the postgraduate medical colleges are already fulfilling that objective. It will be a distraction and a possible punishment to insist that medical teachers who already possess the fellowship certification of our postgraduate medical colleges must undertake any additional PhD program. It will also deprive Nigerian patients of the valuable time of these professionals. In fact, a dispassionate look at research productivity from Nigerian universities will show that in universities with medical schools, over 50% of the research publications from such universities are coming from only their medical school. If you see any Nigerian universities, that is globally obvious. It is globally obvious because of the work in its medical schools. You can Google it and you can check it. All Nigerian universities that are ranked because of the work that is coming out of the medical school. One study in the south part of Nigeria also clearly shows that academics from faculties of health sciences in the universities in the zone have the highest average H index, I-10 index. It is noteworthy that 80% of the lecturers in these medical schools are fellows of one or the other postgraduate medical college. And in the United States and the United Kingdom, the residency training of doctors is considered adequate for them to assume teaching positions in medical schools, and no other degree is required for their career progression. And as a matter of fact, the National Institute for Health in the United States, when requesting for research proposals, request the applicants have a PhD or an MD. The MD in the United States is just the equivalent of our MBBS from Nigeria. The Medical and Dental Council of Nigeria also recognizes that even after you've done all this training, after you have your fellowship, You must engage yourself in lifelong learning. You must continue to update and upgrade yourself with learning. In conclusion, the residency training program has enabled the country to produce medical teachers in country at a reduced cost and simultaneously repositioning the country to be able to expand the number of medical schools and rapidly increase the number of doctors trained in Nigeria. The increasing number of doctors in Nigeria is contributing to the growth and development of the Nigerian health system. In practical terms, increased number of doctors will contribute to improved access to quality health care and improved health outcomes. Availability of qualified specialists in Nigeria will reduce the tendency for outward medical tourism and thereby save the country a lot of foreign exchange. Increasing number of specialists and specialist practice will create additional employment for staff in allied health fields and contribute to the proportion of the national GDP due to the health sector. In addition to the economic gains, there are social gains from citizens being able to receive care within their own socio-cultural environment. There can also be tremendous national pride in local capacity and capability. As earlier stated, a medical or dental consultant is thus produced after 26 to 28 years of formal education, inclusive of primary and secondary school education, which are important foundations for medical education. After these 28 years of formal education, all that he needs to be able to function optimally as a teacher, researcher, administrator, and specialist is continued professional development, as envisaged by the Medical and Dental Council of Nigeria. And as our teaching hospitals, through ward rounds, grand rounds, etc., and other external exposures provide. Apart from the fact that we currently have gross deficits in the number of Nigerian doctors, it will serve no useful purpose to derail them into any other program. Already, they earn better remuneration outside the universities, and imposing additional obstacles on their part will only starve the universities of the required manpower. In fact, at the Lagos University Teaching Hospital, we have consultants who refuse to be lecturers in the university. In fact, when you become a lecturer, your salary is lower than that of a senior resident. So why bother? Why take up the job? Well, I think that Dr. Nira has been giving me signs, and I think that I've tried to be as like a lady skate, very brief, short enough to expose to arouse interest, but long enough to cover the subject matter. I thank you for your attention.
Thank you so much. The presentation I just listened to deserves a better applause, please. That was a performance. Prof showed us why he's a professor of professors. I think after this presentation, we can go out and say, do you know who I am? Like, we can actually go and say, do you know that? Do you know who I am? After this presentation, every one of us, I hope you now know who you are. Thank you so much, Prof, for that insightful, enlightening, uplifting, now I'm practically wearing shoulder pads. Without wasting much time is no longer on our side. We're going straight into a panel session. Following this presentation, I'll invite, my co-moderator is saying 20 minutes maximum. I will invite Dr. Laja to moderate this session, as I'll once again invite Dr. Laja, please.
Good evening, everyone. It's been a very long and interesting day.
But this is actually a very, very important topic that actually eats at the fabrics of our existence as an organization. And that is the role of public health physicians. As a member of the Aphpn, this particular topic has troubled our minds because increasingly we have graduates from the college, either West Africa or national. But where do they fit in apart from the teaching hospitals? And that's a subject of reflection for all of us. And that's where we're going to have some time to talk about this afternoon. And to actually support us on this panel, it's my pleasure to invite my teacher, my mentor, my very senior colleague, Professor Aphpn, to come to the high table. I will also want to invite one of the largest employer of doctors in Lagos State, in person of a seasoned pediatrician, by the way, but who has an affiliation for pediatrics and public health. It's my pleasure to invite Dr. Abimbola Mabokute, Permanent Secretary, Health Service Commission. We can't do this without inviting those who are actually involved in the training of the residents. So I want to quickly invite to the high table Dr. Yinka Goodman, the head of Department, Community Health and Primary Care, LASU. Please, a round of applause for Dr. Yinka Goodman. We also have on the panel one of the medical directors in one of the hospitals in Lagos State. Please welcome Dr. Folashade Fadare, a public health physician who is lucky to be heading an hospital in Lagos State. Please, a round of applause for Dr. Fadare. We actually had Dr. Sule Salame, the Deputy Registrar of the National Postgraduate Medical College. He came in earlier, but he had to leave. Unfortunately, he had to leave. We're planning to get him online so that he can be part of this session. Just like I said, this topic has been something that has been very germane in our mind and has troubled us and became more a troubling situation for me when I became the first vice chairman of the association. And I kept on asking myself, apart from working as a lecturer, what else can a public health physician do? Because each time I have to see an advert from Dr. Mabogunje's office, I never see them want to recruit public health physicians. And during my residency training, when I went to Ife, I still remember the pediatric surgeon who was the CMD then. He kept on saying, what are they going to do? What are they doing? And even when I came back to the Health Service Commission in Lagos State, I also had a similar problem. Luckily, Dr. Onoiga is seated there because I worked with her. I mean, she was my director of medical services when I came back to join the service. It was the same issue. What is the role of a public health physician? And what can you do? So the topic is, we're discussing this because we're looking at how we can reshape ourselves and how we can actually let the employers of labors know our importance. And I'm very glad that Professor Oshibogun started by saying you need to know who you are. And I'm sure we know who we are now. Even if we are forgotten, we know who we are and we're in a better position to actually talk about this. So, ladies and gentlemen, welcome to the panel. My first question is to Prof. Sir. And I want to ask you, what value do you think a public health physician add to secondary care practices in Nigeria, sir?
Your question is very specific. So as far as secondary health services are concerned, public health specialists are experts in management, so you can help them plan, develop programs, and manage even the facility. So when I became CMD, the first comments I had was that, what does he know about patient admission? If he's a public health physician, within 6 months, the hospital will collapse. I served for 8 years. And without being modest, at least the minister commended me when I finished. You know, when I became CMD, the hospital had about 900 surgeries per annum. Within 2 years, we increased the number of surgeries to 5,000. It's only management that can help you to do that, your knowledge of management. The other very important area, of course, is in epidemiology, you know, tracking diseases, tracking what is happening in the hospital, and then putting in places measures to be able to reduce issues such as infection rates. You know, if you also know the length of hospitalization, what can you do to reduce hospital stay? And those are very, very important. I don't know, because this is not another lecture. Yes, but as I will have told you that during the COVID epidemic, and Dr. Salami is there, you know, in our research pillar, which I had the opportunity of chairing as an epidemiologist, you know, within 1 month, we had told the state government how long should we admit the COVID patients. All over the world, they had no clue. So in one afternoon, as we gave them the briefing, Dr. Salami will recall, we gave them the briefing in the afternoon, and Dr. Boale was also with us. We gave them the briefing in the afternoon. By 7 p.m. news, the national level brought out the guidelines. It's only epidemiologists and public health physicians that have those skills. Thank you.
Thank you very much. Dr. Maboguje, having listened to those expertise that an average public health physicians possess, how do you think those expertise can help your organization in better management of your practice and better health delivery for the community?
Okay, thank you very much. Like most clinicians, we usually think, what do public health physicians do? And it was a question I asked myself for many years. But the more I interacted with public health physicians, I appreciated the role that they play. They look at the entire system, not just the patients, not just the one person in front of you, but collectively looking at data, looking at patterns, looking at things like that, so that they are more effective in how you manage the system as a whole. I worked in the secondary care facility for a long time, and then I went to primary health care, and I met fantastic people that knew what public health was and how to access community and make sure that what policies we make in our offices gets to the grassroots. And I think that's what public health physicians do. They ensure that whatever policies are made gets to the grassroots. They use data to make sure that we're more effective in making policy and carrying out the what needs to be done. So yes, public health physicians are extremely important. We need them more in the system. And as I said, they look at the entire system, not just the one patients that we see as clinicians. So they tie it all together.
Thank you very much. My next question is to Dr. Goodman. What skill sets and mindset do you think today's public health physicians should have for them to be employable? Because the truth about it is that your hands need to be dirty. So what are those skill sets do you think today's public health physicians? Because I said earlier, each time you see an advert from a teaching hospital, from a secondary care level, you don't see recruitment opportunities for community physicians. What are the gaps in training that you think needs to be met so that they can be attractive?
Okay, in recent times, not just recent times, we know that public health physicians and training, they have the technical expertise. But beyond that, I think that we need system leadership that is needed. For quite a number of our residents that are being trained, well, they have that, but we need to give them more of that exposure so that on their own, without feeling inadequate, they would be able to stand on their own. So even in our curriculum, I believe that should reflect more. And beyond that, I would also recommend or suggest we do a lot of financing, because somehow, I remember when I became a fellow, as regarding financing, I just felt a bit inadequate. I didn't feel I was adequate enough. So personally, and because of the virtue of the work I was doing then, I had these exposures. I had to go for like 3 different courses in financing and things that would require budgeting, having to look at profit loss accounts and all of those kind of things, that by the time I was done, people wondered at times, oh, are you an accountant? So that it's easy, because there are so many times, oh, you've been asked to budget for something and then you've under budgeted for it and you don't even know what to really put in. So I think that is important. Also, I know, especially for those of us that work in tertiary facilities, there are many times we feel maybe some other subspecialties, they are trying to pull the weight with us, you know, that kind of a thing. But in all honesty, personally, I've never been bothered. And why am I saying that? The truth is just because we're in that teaching hospital space for those that end up working there. We look at populations, they are looking at individuals. Put them in the middle of populations, they're going to get lost, because they won't even know how to start, where to start, how do they engage the community and all of that. So for those of us that have that, we need to put that at the front burners. We know how to engage communities, and we're not just leaving these communities, and then we can make that a sustainable thing. Thank you.
Thank you very much. Dr. Fadari. You have an open check to ask your peers. What are the operational challenges you face as an MD of an hospital that you think a public health physician can help you solve? You have an open check now.
Well, I want to say that Prof. Oshibogu mentioned something. Know yourself. There are many roles that the public health physician can perform in the general hospital. Many a times we don't know. For example, when we talk about quality improvement, when we talk about relationship between our patient and ourselves, we leave it in the hand of medical social welfare. And I want to tell you, there is no other person that can communicate well with patients, especially with all these litigations. I will tell you, as MD, I go down to handle some situation that ordinarily when it comes out, it will have been a medical legal issue. But just emotional intelligence, leadership, many of those things that Dr. or Professor Oshibogu mentioned, they are skills that public health physicians pick along the way, which a typical doctor that study pediatrics, that study surgery, does not have. A typical O&G doctor only want to know what is the blood pressure of the patient, what is the dilatation, prepare the patient, and the patient go to the theater. But I want to tell you, a public physician need to interface to let the patient know why he needs to go in for the surgery. And these are gaps that we have in the hospital. That when you have a public health physician that knows his onions anyway, he will be able to fill in this gap. A patient is going in for surgery, a patient cannot afford payment. You interface with them, you talk with them. We're having challenges in our hospital. I will tell them, tell me the community. go and meet the community elder. If I'm a pediatrician, I won't think that way. But because I have public health idea, I will say, go to Yaba, go to the market, go and speak with that woman in the market. We are seeing this. That is why the ministry and HSC should put in public health physician in the general hospital for a better services. Thank you.
Thank you very much, Dr. Fadare. I can feel the passion. I know this is a cause you're passionate about. Prof, sir, many young doctors and even medical students, they see public health as not attractive. They see it as non-clinical. And I remember my days in Ife. They used to call it Komuobe. I'm sure Elo can relate to this. They call it Komuobe. That is, community health is obe, is cheap. How can we change this perception and make it more appealing to medical students and even at postgraduate level, sir?
Thank you very much. I think that perception is already changing. Now, in our MPH program, we have people who have fellowships in obstetrics, in pediatrics, in different. They are all rushing to come and take the MPH. You know, because with the MPH, you are relevant in global health, you are relevant in international health, you are relevant in health management consulting. So there are several opportunities. And even in general hospitals, I forgot to mention, in fact, in virtually all big hospitals in the United States, you must have an infectious disease epidemiologist. Because they already know that they want to control infection rates, because if you operate a patient, the infection rate is what is going to keep them to stay here. So, you know, so that is already standard in some countries. So they already know that they need them. And then, of course, if you have a hospital that have over 100 members of staff, you should plan for their own health. Today, where I'm coming from, we had to recite the Hippocratic Code, and it says, doctor, take care of your own health, take care of yourself. So there should be an occupational health service in any big hospital, any hospital having more than 100 staff, so that periodically you examine them so they don't drop on the job. Thank you. I hope I answered your question.
Yes, you did, sir. Excellent, sir. My PS man, what do you think are the roles that public health physicians can play in helping government to plan better use of their resources as a state? And we want you to use Lagos State and the Health Service Commission as an example.
Okay. So as we have said and rightly said, they do a lot of coordination. And by the way, Dr. Fadare, I don't know why you were using pediatrics. Because I personally, I have a master's in community pediatrics, which means I have some public health knowledge. Anyway, so what role can they play in the hospitals is what you're saying, yes. So like we've said, you are system connectors as public health physicians. You have systems training, you have knowledge in epidemiology, health economics, and things like that. So, for example, if a public health specialist was in a hospital like Massey Street Children's Hospital, they will help the MD in connecting the dots, basically. So we have an outbreak of cholera. Where is this? Apart from the fact that you have community people doing that, the public health physician will use that data to ensure that the hospital is more effective in their output. You are there to map services and make sure that workforce and programs are carried out properly. Also, you use evidence to prioritize what needs to be done and what can wait till later. And then a lot of monitoring and evaluation is part of what is done by public health physicians, which we clinicians might not take as important because we're only looking at one patient at a time. You know, so I believe public health physicians are necessary in our general hospitals.
Thank you very much. Thank you very much. Dr. Goodman, how can the teaching hospitals reflect the needs of the society in the training system and ensure that the output of the trainers actually meet the needs of the society.
Thank you very much. I know that for our residency program, we have residents having to go to local governments. They do go to local governments, they go to the State Ministry of Health, they're involved going to some other organizations, rural posting and the rest of that. But aside that, if residents have gone for this training, I believe they should be able to identify gaps and identify priority areas so that when these areas are identified, one of the things I think is very practicable is, can we have dissertations tailored along these priority lines or priority areas? And at the end of the day, that becomes very meaningful because it's like meeting the needs of the state, meeting national needs. And at the end of the day, if a resident doctor should do this, or if we have a lot of us doing this, that kind of finding will not just remain on your shelf. It will not just remain, it could even, we could use this to develop technical reports, and I believe that would inform policy and the rest of that.
Thank you very much. Thank you very much, Dr. Goodman. Dr. Fadare, are there ways in which public health physicians can improve patient outcomes and also improve overall management of patients in secondary facilities?
Much. Prof already mentioned it. If there is infection prevention control physician who is a public health physician, it looks at the data, ensure that from time to time water samples are taken for culture sensitivity, swab are taken on, and you look at data of surgical wound breakdown and all that, nosocomial infection, hospital can have the pattern of antibiotics to use and all that. And from this, you find out that the hospital is working based on evidence-based and data-driven care. Before I came in today, I had to go to my clinic and I said, one of the data I noticed is that patients that register here, they have babies that are asphyxiated. Why would our registered mothers have asphyxiated baby? Checking into the monitor of your pathogram, checking into obstetric care. Because I am looking at data, I know as a public health physician, I don't expect to see this. So you will use data. I use data. And once I see, because of my experience, I will not look at one patient. I look at everything holistically, and I'll say this. Why am I having more of this? So if we have public health physician, he will be able to say this and this, plot the graph, and give recommendation. And we will be better off. We will offer quality service in all our hospitals, and we will have a world-class experience as we go to our hospitals.
Thank you very much. The day has been fast spent. We just want to take closing remarks, sir. Any final words, sir, as we round up?
Thank you very much. It's just for us to rediscover ourselves and to know our capabilities. In rounding up, I will just remind us about the My Pikin saga. It only takes a public health physician to unravel outbreaks. You know, during the My Pikin saga, it started, ABU recorded about 7 or 10 or 14 babies with renal failure. Nobody knew what was happening. The moment we recorded 7 at Lutz, I called my HOD, send me 4 resident doctors. We started looking at all the data and then mapping out what drugs were given to the babies in the last 1 to 2 weeks. And when we unraveled it, we were looking at attack rates for each drug. So we said My Pikin and one other paracetamol brand. So the NAFDAC people, because I had called the Honorable Minister that there was something coming out in the country. So he had invited NAFDAC to come to see me at loot. I made the mistake of telling them my finding. Again, by 7 p.m. news, NAFDAC closed down Barewa, I think it was Barewa Pharmaceutical.
Yes.
They closed it down and started all the noise. Nobody recognized the role of the public health physician. Thank you.
Excellent. Excellent. Dr. Mabogunje, I'm going to put you on the spot. Will you have committee of physicians as on the list to be recruited in your next recruitment exercise? Yes.
That's not fair, Dr. But I agree with you. We need to reform our policies.
Excellent.
We need to improve our recruitment strategies.
Excellent.
We need to update our schemes of service so that it includes public health physicians.
Excellent.
Thank you.
A round of applause for Dr. Mabogunje, please. Final word from Dr. Yinka Goodman.
I'll just say, sincerely, this has been very enlightening. It's given us more opportunity to participate. And last words, I think for our residents, the program is okay, but for us as trainers, we need to be able to mentor, get to involve ourselves more in mentoring residents so that we give them the necessary exposure they can ride on our collaborations and all that. And then I also want to say, for quite a number of us, we may have certain collaborations, maybe an individual somewhere. As much as possible, this shouldn't rest just with us as individuals. We should make it institutional. And I think that would go a long way. So it doesn't matter whether Dr. A is here or not. It doesn't matter. It becomes an institutional collaboration. Thank you.
Thank you very much. Dr. Fadare, your final word?
I will be ready to work with HSC to come up whatever it takes for us to have public health physician in terms of role, in terms of what we call scheme of service, so that we can package it and it will now be able to help them as a paper that will be used to put them in the scheme of service. Because as we speak, you can only say you are employing a surgeon, a pediatrician, an obstetrician. So we will see what the role, and we will put it and we'll present it, and they will help us. But I will also want to say, when you are training, remember to also post them to the general hospital to have idea and see how they can fit in. Thank you very much.
Thank you very much. On that, please, I think the panelists deserve a very big round of applause for what they've done. So I want to hand over to the chairman of the session, Dr. Atinuke Onoyiga.
Appreciating each and every one of you for giving us an opportunity to have this robust discussion. Now, I would like to let you know, even though the moderator worked with me, and at that time, it was rudimentary in the history of Health Service Commission to actually recognize, give the respect that is to be accorded to what public health does as a role. And I can tell you that from then henceforth, we are alive today because of some visionary leaders who knew in manpower planning that there were like minds that see. So, and I want to use this for every one of us, that once you're a public health physician, your DNA should know that you no longer think about clinically one patient to yourself. You think about a group of people and how outcomes that will come from anything that will affect you. So you begin to intervene and then to give interventional solutions to them. And that's what has been laid down before. And I'll give you the examples that, yes, public health people were, oh, why do we want public health? I remember the then permanent secretary when I was a director of medical services, and already I had an MPH. And I thought the way I'm thinking, I started cropping up all the MPHs. I started cropping them, and then I would discuss with the commissioner, Dr. Iriti, say, if you don't need them, just send them to me. I can tell you that the formation of that group is what perhaps helped us in the Ebola crisis. Today, that we should give kudos to that you as a public health physician and as a collective group, we were helpful to helping to abort that crisis. And even the expansion of it into COVID-19. Now, one other thing that we didn't mention here is manpower planning and utilization. Manpower planning is very crucial, and that is leveraging on us as public health physicians. You know, if you are there in, that mandate that we have in Health Service Commission is actually for all health workforce, to recruit them, to retain them, to plan for their career progression, their training, and at the same time, to do a lot of monitoring and evaluation to have the quality control of our hospitals. Now, in all of that, the mind of a public health person is a mind that can encapsulate all that. So, how do we now distribute our manpower, even when you've been successful enough to have public health physicians there? I'm afraid even what we have now, because we do have public health physicians right now, but what we have is we are not utilizing them maximally. And I can boast to you that the Directorate of Medical Services, where they are, is the engine room of Health Service Commission. Correct me if I'm wrong. So please clap for yourselves. And every time we have placed public health physicians as medical directors of hospitals, there has always been remarkable differences. It's not that I'm boasting or anything. We have noticed that. So now what we need to begin to do is, first of all, know yourself. Know your DNA. Appropriate yourself anywhere you are. In my home, in my estate where I was, when I first got there, the first thing I noticed is that, they are not sanitizing this water. The water we are having here is not wholesome. And immediately I told them that take the specimen of water, go there. And everybody was like, Dokito, just started. But by the time the results came out and they saw all the organisms that were there, and they said, hey, be careful, or even our children are in danger and everything. So now, every quarter, there are analyses of the water that we use in that estate. Every day, one just came out today, the result, and then they send it to everybody so that their minds are at rest, that they can use it to bathe their children, to wash their clothes, to perhaps cook their food, and if you don't want and you are more obsessed, then you can drink the bottled water. So wherever you are, please apply yourself as public health physicians. You have a role to play. You are the voice. You are the analyst. You are everything encapsulated in what has been said today. And I tell you, apply yourself anywhere you are. I can tell you that a lot of formatting was done at the Health Service Commission. Ordinarily, if you leave it, a clinician will just see the patient and write things in proses. But when they want to write proposal to present to the governor, to this, they call a public health person within our directorate. So it has become a known thing that, yes, the public health physician has really a defined, specific, and a role that, you can't tell someone else to fit it in. So please, in consideration, and I know that our PAMSECs are getting to know this, and so they are taking in public health physicians, not necessarily that they will pull them by the side and say, what do we need them for? What we need is gynecologists. What we need is this. They also look at it that for every 4 that you've taken as clinician, you should be able to take 1 or 2 as public health physician, because they will plan everything that you will want, and this will help your service outcome to the things you deliver to the populace of the Lagos State or the community. Thank you very much, and thank you for coming. Thank you for making us have this robust discussion. I believe that we are all going to benefit from this, and we will not be set aside anymore. So please begin to recognize, respect, and remunerate public health physicians anywhere they are.
A round of applause for the panel members as they go back to their seats. Thank you very much.
Thank you so much for your patience, everyone. Lunch has commenced already. We will continue in the same light. Row by row, you'll be called upon or ushered to the buffet section for your lunch. Thank you. I think we're on the second row now. So, ma'am, the vote of thanks will be taken while we're having our lunch. Dr. Fadari, if you don't mind, I'd like to crave your indulgence to give the vote of thanks while.
Standing on the existing protocol, I want to appreciate everyone that have been here, all our panelists, our special guests, our professors, and our distinguished public health physician, all our permanent secretary that have been with us. I want to say thank you very much. It has been a great day. Thank you for being there. And for all our esteemed people that are online, that have been following us, I want to appreciate you. Your presence there have made a difference. We believe that today we have sent the message, and I want to tell you tomorrow is going to be a very great day. So we'll be starting by 9 o'clock tomorrow. Be there with us. The lunch is served. Let us enjoy the meal. And I pray for traveling mercy back. Let us rest early and wake up early to be part of this wonderful Biennial Scientific Conference of Aphpn Lagos chapter. Thank you very much for being there.